Hey guys, am I audible? Am I visible? Good evening, Subhajit. Good evening, everyone. Hope I'm audible and visible. If so, say me a hi and a hello. Meeting you after a week. I hope you have completed hematology of FARRE, whatever we discussed, the RBC, the platelet, and the WBC disorders. Like I said in the WhatsApp group, I'll be taking 4 sessions continuously, consecutively, which will cover almost everything required from systemic pathology. Today, as you can see, we'll be going with CVS and lung. Then we'll be going with your GIT and liver. We'll go with kidney and MGT. We'll go with breast and FGT, right? That will cover almost everything required from a systemic pathology point of view. I'm going to do the same thing. We have a pre-written template of thing and we're going to discuss, and I'm sure you will actively participate so that we can make the revision much more comprehensive and much more useful for you, right? Hello, Sohana. Good evening. So good evening, everyone. So tell me, first of all, to kickstart the discussion, let's go a little bit non-academic, right? So when is your exams? Can you guys put down when is your exam? When is your uh, second prof exam? Have they announced? Have they not announced before going to the subject? Subhajit, Sohana, tell me guys, when is your exam? Good evening, Achintya. When is your exam? Let me know. How are you doing, Achintya? Okay, so let's the answer keep coming. We'll go into the session straight away without wasting much of time. So we are going to discuss about CVS as well as lungs. So CVS, if you look broadly in CVS, one of the important thing which I feel as an examiner is definitely a question on myocardial infarction, atherosclerosis and related things, right? Great, guys. And with respect to vasculitis, I might not ask a long answer, but vasculitis like polyarteritis nodosa, the vaginas, all of them are very, very good question for short answers by default, right? And the vascular tumors also very good for short answer, very unlikely to come in a long answer. But MI is definitely possible to come in a long answer. And also your cardiomyopathy, because cardiomyopathy also is very important. It's not something which is frequently explored, but there's a possibility for it to come in a long answer, right? And I cannot ignore rheumatic heart disease and vegetations by default, right? So with this note, we'll go into the first topic. The first topic is atherosclerosis. Before me going to this template, like what we have been doing for the last two FARRE, same way, I'm going to ask you a few questions. I want you guys to answer. With that, let's kickstart with atherosclerosis, right? Can anyone tell me at least one modifiable and one non-modifiable factors for atherosclerosis? The risk factors. You definitely know one modifiable, one non-modifiable easily, right? So in atherosclerosis, we call it as a risk factor. We don't call it as an etiology. You know why that? Because all obese patients will not end up in having atherosclerosis. It's a risk factor. All diabetes will not end up in having atherosclerosis. It's a risk factor. That's all, right? You guys answered very enthusiastically for your day of university exam. I want you to answer theoretical questions as well, not just these questions, right? Come on, guys, tell. Luffy, KDR, Arya, chat history, great. Lifestyle, gender, modifiables, alcohol, smoking, amazing. Come on, keep flowing, right? So whenever I'm going to have a starting point, we always start with etiology, pathogenesis, gross microscopy, and then the clinical features, right? With respect to atherosclerosis, we do have non-modifiable risk factor like age, definitely cannot, gender cannot, and this probably might come in a reasoning why question, or it can come in a viva. Postmenopausal female and premenopausal women, postmenopausal males and males and postmenopausal females are at equal risk, and the premenopausal women are protected by estrogen because they protect the endothelial injury, right? They'll have less chance of atherosclerosis. People who are in the reproductive age group, women, they have less chance of atherosclerosis, right? Good evening, Pawan. Fine, perfect. Then ethnicity. It's definitely a little bit more common in Asian because of our insulin resistance and our diabetic prone genotype specifically. It's more common in Asians. And there's an hereditary risk of hyperhomocystinemia. If you remember your biochemistry, you must have read about something called, there is an enzyme called cystathionine beta synthase defect, right? Cystathionine beta synthase defect is going to be an hereditary increase in case of homocystinemia, right? I'm just going to ask you one more question. Let's see how many of you can answer. Can anyone tell me one acquired cause of homocystinemia? It's there. I'm just going to pull it down so that you will answer it, right? Great, Subhajit. You have completed almost everything required. Any one of the acquired cause of hyperhomocystinemia. That's a modifiable risk factor, right? Because vitamin deficiency also can cause hyperhomocystinemia, right? So I do have one condition which can come both in modifiable and non-modifiable. Do remember them. Apart from that, you know the big guys, the metabolic syndrome X, diabetes, hypertension, hypercholesterolemia, your obesity, smoking, alcohol, not a direct cause, but they are definitely contributing factors in case of atherosclerosis without a doubt, right? This is something you might ignore. If you want to get into the place of distinction or honors, I want you to remember this. Infections like CMV, herpes can also slightly increase risk because these both has a capability to cause endothelial injury. The primary factor is endothelial damage. That's it, right? You guys have reasoning way questions, right? I love reasoning way questions because that's where I feel you guys can start thinking. There is definitely one non-modifiable risk factor, which you guys know, it is by default the age. Why is age a non-modifiable risk factor? This reasoning while will suit for why increase in age causes cancer, why increasing age causes heart attack, why increasing age causes stroke. Everything the same answer, right? Because as and when age advances, for all these diseases, what I said, cancer, your diabetes, your hypertensive, we have something called CHIP. CHIP is clonal hematopoietic cells of intermediate precursors, right? So these precursors are in the bone marrow. They get to have some mutations, some epigenetic alterations, right? That increases as age advances. And that is going to create inflammation. Inflammation is a common point. Please don't forget that. If this word is there, CHIP and inflammation, that will be more than enough for me to reason out why age is the risk factor. Because when there's an inflammation can cause endothelial damage, inflammation can cause free radicals can cause mutations and can cause cancer, right? So CHIP is responsible for aging, cancers, and also in atherosclerosis. It's one of the important reasoning why questions, right? So we know the etiology. Pathogenesis is simple, right? Good evening, Mariam. Pathogenesis is very simple. So if you look at the pathogenesis, it's just same cut copy paste of inflammation with respect to blood vessels. That's all. So we have two things here. I wanted to divide here because the first, before going to that, let's ask one more question. Let's make it interesting if you guys can answer. What is the first stage of atherosclerosis? Because the atheroma or the atherosclerotic plaque is the terminal one, right? Before that, we have one stage where you'll have a tiny lining of yellow color material there. It will not cause blockage of the blood vessel or anything. What is it called as? Can anyone tell that? A very tiny lining. We call it fatty streak, right? So fatty streak, we have divided that. It's a first stage. Then obviously, it will continue to form an atherosclerotic plaque. Many people ask me, should I draw an amazing diagram? See, this is it looks neat, right? But it's a very simple diagram, that's all. You put a circle. If you want to replicate this diagram, just put a circle. That's a lumen. Just draw a line. Draw an yellow color, mentioning the fat deposit. Put a pink color, mentioning the necrosis, and then on top of it, draw fibrous capsules. That's all, right? It need not be a beautiful diagram. It just needs to be simple hand-drawn diagrams. That's all, right? Satabdi, I will put that in the WhatsApp group and also will be then the Telegram group of PW. Fine. Okay. Perfect. Let's go to the pathogenesis. Quick revision of pathogenesis. First of all, atherosclerosis is nothing but a chronic inflammation of the blood vessel wall, where macrophage is the main inflammatory cell, because by default for any chronic inflammation, the cell of chronic inflammation is macrophage, right? So the first and the foremost point which is required in the answer sheet is, what is the starting point? Starting point of atherosclerosis is something called microvascular damage. The microvascular damage can be due to hypertension, can be due to hyperlipidemia, can be due to anything. But most of the time, once there's a damage, the damage will help the cholesterol. This word is important, not just any LDL, oxidized LDL, right? Oxidized LDL is the one which causes damage, and then lipoprotein. All these will go and enter into the endothelium. The moment it enters endothelium, if you remember pyroptosis, you must have read about a pathway called an inflammasome pathway, right? Satabdi answered it. It will be there in the Telegram group of PW. Please take care. Fine. Okay. So it will activate the inflammasome pathway. Once inflammasome pathway is activated, the interleukin-1 beta converting enzyme will be activated. That increases interleukin-1. What will interleukin-1 do? It's a chemoattractant. That's all. My fat went into the endothelial layer, caused some damage. So lots of WBCs are going to come and remove the fat. That's it, right? So it will attract monocytes, convert them into macrophages. Macrophages will eat the lipoprotein A, oxidize LDL, whichever caused the damage, right? So this will result in macrophage accumulating in the endothelium. The moment macrophage accumulates, we call them foamy macrophage, because foam is clear. Clear is fat. Can anyone tell me what will be the gross color of fat? Fat is clear in microscopy because it is washed away, right? It's been washed away. Gross color of fat will be yellow in color, right? It's just a diagrammatic representation. Here, I don't have much of a trouble at all. There's a single lining of endothelium. Along with that, I have few more macrophages that are sitting there. That's the first stage, which we call it fatty streak. Is that clear till now? Yes, no, maybe. Hi, Siddhi, good evening. Yes, perfect. So this is the simplest pathogens of the first step of atherosclerosis, which is the fatty streak. Now, this fatty streak is reversible by default. It's an inflammation, right? If I can control all these things, very difficult to do it, right? If I can control, it will not progress at all. Fatty streak can be seen in infancy. You have fatty streak in your arteries. I have fatty streak in my arteries. That's how it is. If I don't have diabetes, hypertension, I exercise properly, I don't eat too much, cholesterol levels is normal, this fatty streak will not progress to the next level. If I don't control that, if all the risk factor persist, that is very, very, very important. For me, the risk factor should be persistent to cause it atherosclerosis. That's why diabetes, hypertension are all chronic lifestyle changes. It's not an immediate effect, right? Over the period of years, fat, macrophage, everything keeps on accumulating. The interleukin 1, whatever came, will cause cell death, obviously. And Pavan said exactly, it will end up in having tissue destruction, healing by fibrosis. The moment tissue starts destroying, fibrosis will definitely happen. But endothelium is a simple squamous epithelium. For fibrosis, I need fibroblast, right? From where will the fibroblast come? The fibroblast will be myofibrils will be pulled from the tunica media. From the tunica media, the spindle cells will go into the endothelium and will metamorphose to form the scar, right? It will definitely heal by fibrosis. Now, this healing by fibrosis, this entire lesion, you can draw a line here, a simple line, put a bulge here, because healing will automatically have more cells. In the center, I have necrosis. You all know that color of necrosis is pink. You have few foamy macrophages, yellow rounds. On top of that, pink color fibroblast. This is what will happen. And this is called as an atherosclerotic plaque. Plaque means irregular. That's all. That's all. An irregular bump over a smooth muscle, that's a tunica media, is atherosclerotic plaque. We also call them new intima, or use the term neo-intima. If there's a 2-mark question saying, write a short note on neo-intima, it's not something different. It's same atherosclerotic plaque because it's not a normal intima, right? What is normal intima made of? I'm going to take Viva and I'm going to teach together, right? Tell me, what is a normal intima made of? Normal intima is made of? You know the answer. It is endothelium only. But here, I have endothelium, I have WBCs, I have necrosis, I have fibroblast. That's a neo-intima formation, right? So this neo-intima has 2 components. The fibrous cap, which is fibroblast, myofibroblast, obviously it will have collagen. Every scar will have at least a little bit of collagen without fail, right? Then I have a necrotic core, which will have necrosis, fat, cholesterol crystals, and macrophages, along with little bit of your smooth muscle, right? Smooth muscle is not an important component here, but yes, it might happen, right? So that causes your atherosclerotic plaque, fine? Okay, thank you, Bhavan. Yes, Satapti. Amritansh, yes, okay, fine. Okay, so this is what's going to be atherosclerotic plaque, right? There can be a 5-mark question which can just ask you what will be the outcomes of atherosclerosis. Can anyone tell me, whatever comes to your mind, the outcomes of atherosclerosis? We know the etiology, the risk factors, we know the pathogenesis. Obviously, I need to know the outcome, right? There's a chance of me asking a 5-mark, the outcomes of atherosclerosis. I'm not specifying any particular organ, just tell me the outcomes. Tell 1 or 2, let's fill up the rest. Come on. Amritansh, I want you to answer it, right? I'll definitely give you the notes, right? You message me personally, I will personally send you the notes if you don't find it there. Stenosis, amazing, Pavan. Rest. It can stenose it, right? Definitely when the stenosis happens, my blood supply can come down, which can cause ischemia, which can cause infarction. Great area. I can recanalize. If it's not a very vital organ, like maybe a little bit of artery here, this death will not kill me, right? Skin death or muscle death will not kill me. There, it can recanalize. Perfect, Subhajit. This is a scar. Will scar weaken the tissue? Any day. So scar in a vessel will weaken the vessel. When the vessel weakens, can I have an aneurysm or a bulge? Obviously. When I have an aneurysm, that will cause thrombus because virtual state is altered. That will cause embolism, right? Amazing. Kanika, I would not put DVT here because DVT is venous, right? Atherosclerosis is very, I won't say impossible, very rare in venous. Maybe put it last, fine? Okay, perfect. The first thing for me is a critical stenosis. When will I call it critical stenosis? When you have 75 to 90% occluded, the lumen is occluded, it causes critical stenosis. If it's in the coronary artery, it can lead to MI. If it's in the cerebral artery, it can lead to stroke. Always please give a clinical disease. I'm not going to talk about the vessel problem alone. I have to link it to the human being who is the patient there. Coronary artery disease blocking with critical stenosis causes MI. The middle cerebral artery blocking with critical stenosis causes your stroke, right? Then, if the scar tissue is present and the blood can recanalize. So, recanalization mostly will happen in non-vital organs. Because vital organs, heart and brain, I don't give enough time to recanalize. The patient will end up in a serious problem, right? So in most of the non-vital organs, recanalization can happen. And like you guys exactly said, the plaque weakens the vessel wall, which results in aneurysm. By the way, atherosclerosis is the most common cause of aneurysm almost in entire organ in the every vessel in the body, except, can anyone tell me, in one part of the aorta, atherosclerosis is not the most common cause. What is the most common cause there? In only one part of the aorta. And atheroembolus, which can lodge anywhere because aneurysm can itself cause increase in risk of thrombus. Not just that, the atherosclerotic fatty plaque itself, right? The fatty streak and the fatty collection itself can break and can dislodge, fine? Yes, Pavan, it can break. And thrombus also can form and it can also go there, right? Okay, the answer for the question which you asked you is ascending aorta, okay? It's ascending aorta. In ascending aorta, the most common cause is hypertension. In rest, every aneurysm, the most common cause is not hypertension. Okay? It is atherosclerosis. Only in ascending aorta, the most common cause is hypertension. Syphilis, yes, you are amazed, you are right, Kanika, but the only thing is, it is not that common. That's all. Fine? Perfect. Right? Over the period of time, you can have an angina or an infarct, superimposed thrombus can happen. This will result in your unstable angina. Okay, that also can happen. It's not just the critical narrowing. I can have a thrombus superimposed on top of it, can completely block the blood supply, can result in unstable angina or infarct. Fine. Okay. Done. Perfect. So these are the outcomes of atherosclerosis, which can easily come in a 4-5 mark question, right? I'll just zoom out. It's a single page. This is what we have done for RBC as well as platelets. And also WBC, we have one page which will help you to quickly revise the day before the exam. That is the primary motto of FARRE. FARRE's motto is to revise what you already know, and you can easily have a pictorial memory. Okay, it was here, let's reproduce that, right? Can you go to the next question? Yes, no, maybe. Only when you guys say yes, I'm going to go to the next question. I want active involvement. Why should I alone shout, right? You also shout there. Only when you say yes, I'll go to the next question. Otherwise, we'll call it off. Okay? So the next question, I'll tell you a simple history. I want you to think and tell me what could be the answer. A patient came to the emergency department, an extremely excruciating pain in the chest or in the abdomen, right? And this pain in the chest is going and transmitting towards the edge of scapula or radiating towards the back. What will be the clinical diagnosis? What will be the clinical diagnosis? Excruciating chest pain radiating to the back. MI will not radiate to the back, no? MI radiates to the left side of the arm, right? Kalamuri, Shriparna, right? It will go to the left side of the arm, right? I won't call it an radiating to back. If it's radiating to back, it should be something else. Excruciating pain radiating to the back. MI angina, you're absolutely right. I'll give you an extra word. The question said there's a tearing pain. There's a tearing pain. If you have a pain in the chest or in the lower or in the upper abdomen, which radiates to the back, I want you to think of dissection than MI, right? I'm not saying MI will not present, but it's a tearing pain radiating to the back. Left arm is different, neck is different, back is different, right? Most likely it will be aortic dissection, right? Okay, just remember it. But follow-up question might give you an answer. I won't categorically rule it out, but if it's classically saying tearing pain, I would prefer an aortic dissection, right? What is aortic dissection? As the name says, it's dissecting, that's all. Aortic dissection, the blood travels between the tunica media of the aorta, right? If let's say it's a normal aorta, there's a tear in the intima, and what happens? The blood travels in the tunica media. This is dissection, that's all. There's a possibility it can tear here, it can travel here, it can come back again. That is called as doubled barrel aorta. I will have a blood traveling here, it will tear and it will come back here, so there will be a channel here, right? So you'll have one channel going in the normal lumen, one channel going between the tunica media, that's the second lumen, fine? Okay. Shripanna, I'm not sure what is DVT due to CHF. Can you explain that? I'll try to answer it, right? So that is double barrel aorta, fine? So now for the blood to travel to the media should be extremely weak. So what makes the media weak? There comes my pathogenesis, right? There are two important things in aortic dissection. I want you to mention both. The common cause of aortic dissection by default is hypertension. No one can take it off, right? But yes, also Marfan syndrome. Because you know for a fact, in Marfan syndrome, I'll have a problem in the aorta where the elastic artery will be destroyed. A deviation question. Can anyone tell me what is a gene mutated in Marfan syndrome? There's a very likely possibility this can come as an MCQ in your first paper. I'll continue this. I want you guys to comment on the answer. Fine. So you have hypertension and you have Marfan syndrome. Because of hypertension, you'll have an upregulation activity of TGF-beta. Detour, Marfan syndrome also because of loss of fibrillin 1. That's a mutation, by the way. That results in upregulation of TGF-beta. That increases the TGF-beta. Fine. Fine. In case of classical hypertension, the angiotensin receptor and the TGF-beta are almost similar. That goes and binds to the TGF-beta receptor, which overactivates TGF-beta receptor. The moment TGF-beta receptor is going to get overactivated, that TGF-beta receptor overactivation will destroy tunica media, which is made of elastic fibers. Because these receptors are there in the elastic fibers. No one answered for Marfan syndrome. That's bad. I'm going to ask the question once again. Mutation in Marfan syndrome is seen in fibrillin 1 gene or fibrillin 2 gene. Let's see if any of you guys can comment on that. I want you guys to comment on this. I'll continue the lecture, but I want you guys to comment for sure. Fine. Okay. This is what is going to happen. So hypertension or Marfan's, I'm going to have excess activation of TGF-beta receptor. That TGF-beta receptor is going to destroy the elastic fibers in the aorta. The moment the elastic fibers get destroyed, you have spaces like this. Empty round spaces. It looks like cyst for me. That's why we call the term cystic. It happens in the tunica media of the aorta and we call it degeneration. The moment I have cystic medial degeneration, this will weaken the tunica media. Because of this weakening of tunica media, you can have the tear and the aortic dissection, right? So that's the reason for the aortic dissection which happens, right? It is fibrillin 1. See, it's fibrillin 1, fine? Okay. Now, there are two classifications for aortic dissection. Can anyone comment on the classification? We'll definitely look at the classification very soon. There are two classifications for aortic dissection. We call it based on anatomy. The anatomical base of classification was named after a cardiothoracic surgeon who is D. Beckey, right? And there's a classification which is more prognostic classification, that is by Stanford, right? So D. Beckey classified aortic dissection. You will have a beautiful image in Robbins, but those images are not easy to draw them, right? See, it's simple. If you have an arch of aorta, draw that. You can draw whatever branches you have, and then it's a dissection, right? You need not do anything. You just make it thicker to know the blood is traveling in the wall, and maybe if required, put an arrow mark here to point to the intimal break. That's all. Fine. As simple as that. Fine. So we have three types of classification based on D. Beckey: type 1, type 2, and type 3. Where in type 1, you will have from the root of aorta till the origin of first artery. That's where you will have the dissection. That's where the blood will be traveling in the tunica media, right? In the type 2, okay, fine. There's an error here, okay? Ignore that. You'll have from the root of aorta till the iliac bifurcation throughout. Fine, will be throughout, okay? That's one, right? Next, type 3, you'll have dissection starting after the origin of subclavian artery. After subclavian artery, if the dissection starts, we call it type 3. Okay, the beyond the subclavian artery, it's the type 3. So type 1 is till the root of aorta. Sorry, I made an error, not here. And type 2 is the root till the origin of the first artery. My mistake. Fine, perfect. Okay, what Stanford did was, Stanford just changed the classification, made it to prognostic. Stanford kind of said that whenever the root of aorta has some problem, by default, what's going to happen? The risk of them spreading into the heart and spreading into the major vessel increases, right? So he said that more risk is there involving the root of aorta. So he clubbed type 1 of DPK and type 2 of DPK. And here, type B has a better prognosis because it has no involvement of the root of aorta. It has no involvement of the major vessels. When I say major vessels, the major head and neck vessels, right? Okay. So this has a better prognosis, which is equivalent to the type 3 of DPK classification, right? Classification per se alone can come in a 2-mark if you have 2-mark question in your university, but the entire aortic dissection can be easily asked in a 5-mark, right? So clinical features, like I said, it's an acute chest pain or an acute abdomen pain based on where the tear is. If it's involving the thoracic aorta, chest pain. If it's involving the abdomen aorta, it will be an abdomen pain by default, right? Vitals are unstable. It's very, very, very important. Because an acute abdomen pain, this I want you guys to answer. I'll send you the PDF, Amritansh. You listen to the class, answer my question. I'll definitely send you the PDF. Fine. A history of acute abdomen pain, patient smelling alcohol, and the pain is radiating to the back. Can anyone tell me the diagnosis? That is a classical case of acute pancreatitis, right? Here, I'll have almost the same history if the abdomen aorta is involved, but the only thing here is the patients will hemodynamically be unstable, right? It's a very, very close DD for acute pancreatitis. Do remember them. But acute pancreatitis, you'll have no hemodynamic compromise. Your BP will not be there problematic. Fine. Okay. Perfect, Subhajit. You can add your extra knowledge from surgery also. Sandeep sir will take out of that. I am not going to do anything with respect to that, right? Perfect. Microscopy, I'll have cystic medial degeneration. Treatment, if you know, do it. Write it. It's a vascular Teflon graft. You can do and patch the aorta wherever it's dissection, which will give strengthening the wall of the aorta. That's what they primarily do. Treatment is definitely surgical, but definitely has a very poor prognosis because of surgical emergency here, right? Perfect. Done. That's with aortic dissection. Okay. So what you're going to do next is dissection can come in a 5-mark. Again, next two things what you're going to read also will be mostly in the 5-mark range only. Essay unlikely to ask in vasculitis unless they're going to give a single episode of vasculitis and ask the classification and talk about vaginous, talk about pan, then yes, it can become a long answer. But generally, vasculitis is not something which is concentrated on CBME, so they might not ask you. Fine. Before going to the next question, few queries to you. I want you guys to comment. Amritansh, this time I want to comment the answer and not for the PDF. Fine. I'll give you the PDF. You ping me here. I'll give you the PDF. Okay. This is for you especially. Fine. A patient came with a history of renal failure and the patient kidney biopsy was taken. In the medium-sized artery of the kidney biopsy, there was a transmural necrosis. Same vessel also showed fibrosis. And this patient was positive for HBsAg, IgG of HBsAg. What could be the diagnosis? Anyone? What could be the diagnosis? What could be the diagnosis? The classical case of vasculitis involving the kidney, involving the medium-sized vessels. Diagnosis should be PAN or Polyarteritis Nodosa, right? You guys should not miss the diagnosis because you miss the diagnosis, you might end up writing a wrong answer for a long answer question. Please do remember them, right? Just before going to the next question, I'm just inserting one particular slide so that we can cover the classification also. Classification of vasculitis. We classify vasculitis based on the pathogenesis. We can call them as chronic vasculitis, where TDHF is going to be the outcome, like your Takayasu arthritis and your Jain cell arthritis. Then you have ANCA mediated vasculitis. Then you can have infectious cause of vasculitis as well. Your pan is an infection related vasculitis, your hepatitis C related vasculitis, right? Another way to classify is based on the anatomy. When I say anatomy, small, medium, and large, right? So large, medium, small. Can anyone name the two large vessel vasculitis? This is very easy. I want you guys to comment. I'll go to the medium. I want you to name the large vessel vasculitis. Medium is pan and Kawasaki disease. Kawasaki is something which happens in children, right? Small, most of the ANCA mediated are small. Your Vaginas, your Shrug-Strauss syndrome, right? Your microscopic polyangiitis, all of them are smaller cell vasculitis. Large vasculitis, note takers till now. Come on, you guys know that. We have Jain cell arteritis and we have Takayasu arteritis. Jain cell is also the superficial temporal artery, right? The headache in an elderly person, right? Takayasu is the subclavian artery, pulseless disease. I hope you remember, right? Great, Chitrashi, right? You're absolutely right. Perfect. Done. So now what you're going to do is, I'm going to concentrate on pan. We'll look at Vaginous and Shrug-Strauss and microscopic polyangiitis because all three come under ANCA mediated vasculitis. ANCA mediated vasculitis alone can be a long answer. Fine. Perfect. First to pan. Pan, we know for a fact that one of the important etiologies is chronic hepatitis B. Previous edition of Robin said that 20 to 30%. After that, it moved to 50, 60%, right? It's mostly chronic hepatitis B. The most important thing in pathogenesis, chronic hepatitis B is a waxing and waning course. You will have activity sometime. Immunity is good, the virus comes normal. Again, activity, again, virus comes normal, right? So whenever the viral titer is in the peaks, which means the activity of virus is more, that goes and deposits in the vessel wall. It's a classical example of type 3 hypersensitive reaction. Circulating complex going and depositing the vessel wall. That's all. During the peak, you will have the vasculitis where it will be an acute event. There will be no granuloma formation. Why acute? Because the moment the viral titers become low, the vasculitis event will stop. Again, it will come back. It will stop. Again, it will go back. Again, it will come back. Again, it will go back. This is very, very important. Waxing and waning course or recurring. It recurs. It might recur in the same blood vessel also. That is very, very important. That's the reason pan has a very peculiar microscopic finding. Okay. Because of this, I want this word to be there in the answer sheet. Temporally dissimilar lesions. Which means I will have an acute disease. At the same time, I'll have a chronic fibrosis in the same vessel. This causes a temporal dissimilarity. Temporal is time-wise, right? Which means you'll have acute as well as fibrosis sometimes in the same vessel as well. In the same time and the same vessel, I'll have the problem. And one more thing important is, I'll have transmural necrosis in the blood vessels, fibrinoid necrosis, right? You can draw a vessel, throughout the vessel wall, draw something pink, that is transmural fibrinoid necrosis, that's all. Throughout the vessel wall, I'll have damage, transmural fibrinoid necrosis, no granulomas, temporal dissimilarity. That is diagnostic of pan, right? Pan has a very unique way of involvement of organs. This might come in a Viva. I want you to remember it. Pan will not cause glomerulonephritis. It's very, very important. I have told you the reason in the Nishchay batch as well. Can anyone remember the reason why pan will not involve glomerulus? Pan can cause lung parenchyma spread. Pan will have abdomen pain. Internal GA organs will be involved. Pan renal failure will be there because renal artery will be affected. It's a medium-sized artery. That's the most common cause of death in pan, renal failure, right? Pan will not involve glomerulus. Pan will not involve lung parenchyma for the only reason both of them will have capillaries. Again, a reasoning why question. When you have capillaries, small vessel vasculitis cannot be affected. Fine? That's it, as simple as that. It will involve only medium-sized vessel. Glomerulus is a capillary, lung parenchyma will have capillaries, so it will not be affected, right? There's a very likely chance this can come in a reasoning why question. Fine? 1 second. Sorry. Okay? Perfect. Fine. So that's the clinical presentation of pan. And the way to identify is, do an hepatitis A serology, it will be positive. The same hepatitis A can be positive in the biopsy as a marker also. Pan is ANCA negative. This is important, right? I'll have more necrotic material in the wall of the vessel. Again, if you want to draw, simple. Put a diagram, a lumen, draw cells here, and in few part of the blood vessel, draw completely pink. This is transmural fibrinoid necrosis. It is not difficult. You need not draw an artistically important diagram. Transmurally, I'm having necrotic tissue. No blue cells, only necrosis. That is it. That's more than enough, right? That's about PAN. PAN is supportive management. If you want, add immunosuppressant, add steroids. That will be the way to manage. But primary disease, if I control hepatitis, automatically PAN will come back to normal, right? That's the first disease, first vasculitis. The next, this has 3 of the vasculitis. All 3 are same pathogenesis. The advantage of systemic pathology is read one, replicate. We will read the pathogenesis in vaginous. If the question comes on microscopic polyangiitis, cut, copy, paste. Schuxtos, cut, copy, paste. Etiology changes. Other things will not change at all, right? Perfect. So vaginous granulomatosis, the new name, you have to know about it. It is granulomatosis with polyangiitis, right? We have removed the term vaginous. We call them granulomatosis with polyangiitis. Please remember, if a question comes in other name, you should not say, I don't know. You'll have to still write it, fine? Okay. It's a small vessel vasculitis. It's ANCA mediated. ANCA stands for anti-neutrophilic cytoplasmic antibody. If you're performing very badly in Viva, I'll go to the most basic question. That's at least the expansion of ANCA, right? I hope you will not come into it. It's ANCA mediated vasculitis. There are 2 types of ANCA. We have anti-PR3 ANCA, proteinase 3. It's also was also called as C ANCA, C for cytoplasmic staining. The positivity will be in the cytoplasm. Next is anti-MPO ANCA or P ANCA. We also call them perinuclear ANCA. Previously, we used to call them perinuclear ANCA, right? These are the types of ANCA. So how the vasculitis happens? Let's say I have a tiny vessel. The most important predisposing factor here is neutrophilic degranulation. Whenever there's inflammation in the vessel, right? You have a itching, a streptococcal bacteria came, the vessel is inflamed. The moment the vessel is inflamed, the granules from inside the neutrophil come outside. They are degranulated. And the moment there is degranulation, this patient has antibody in the serum, right? It's anti-MPO. Anti-MPO is a P ANCA, right? So this anti-MPO binds. Antigen-antibody reaction, all of them happens inside the vessel only. And that will deposit in the vessel wall. That causes vasculitis. So the most important thing is, I need a precursor of inflammation happening here. Only when inflammation happens, you'll end up in having a vasculitis. Fine? Okay? That's the important thing about vasculitis. This is the same pathogenesis for vaginous, same for Schuxtos, same for your microscopic polyangiitis or any ANCA-mediated vasculitis. I'll have the same pathogenesis. Fine? PR3 ANCA is seen 100% in vaginous. MPO ANCA is also seen in vaginous 30%. Other 2 are only MPO ANCA or P ANCA, but in vaginous, I see both of them, right? So we know the pathogenesis of vaginous. What will be the clinical finding? Remember, vaginous, see, there should be something we should initiate the inflammation, right? The antigen which should come and trigger the inflammation. That is mostly inhaled antigen. So which part of the body will vaginous affect? The entire respiratory tree. Mostly lung. You can have problems in the nose. Septal perforation can be vaginous. You can have URI. You can have also lungs. Without lung involvement, vaginous can never happen. Bilateral cavities in the lung is diagnostic of vaginous. Microscopy, you'll have granulomas. Why granulomas? I'm inhaling. It'll come again and again and again and again. So multiple acute becomes chronic by default. I'll have necrotizing granulomatosis. That's why the name, vaginous granulomatosis, right? And also in glomerulus, I'll have crescentic glomerulonephritis. What's the other name of crescentic glomerulonephritis? We had RPGN. An acute damage to the glomerulus, destroying the glomerulus, one of the classical things of vaginous. Fine? Okay? That's what is going to happen in vaginous. Done? Perfect. I have something called a limited vaginous when only lung is involved. There is no renal involvement. There's no involvement of rest of the body. I call it limited vaginous. Microscopy, you'll have granulomas. You'll have giant cells. Classical. And also, obviously, you'll have necrosis. See, just because I didn't mention necrosis in vasculitis, doesn't mean you should not write. Every vasculitis will have by default what necrosis? Can anyone comment on what necrosis you'll have? We'll have one type of necrosis here. We'll revise general pathology also, right? Treatment, again, it's going to be immunosuppression. It's going to be steroids. If it is RPGN, very acute damage to the kidney, I might require to do a dialysis. Again, I'll come back to suppress the etiology so that we can have a peaceful, less inflammation here. Fine. Parvesh, I don't know Parvesh. If you ask me, I will say anatomy. If you ask Pawar sir, he'll say pathology, right? It's perspective, that's all, right? The other 2 is microscopic polyangiitis and your Schuxtos syndrome or granulomatosis with eosinophilia. Fine, perfect. Fibrinoid necrosis, amazing. Both of them are also ANCA dependent. So I'm not going to repeat the pathogenesis. There will be slight difference in etiology, there will be slight difference in the clinical history, and a slight difference in microscopy. You won't have caseous, it's fibrinoid, right? So here, microscopic is post-infectious, post-streptococcus, post-staphylococcus, or sometimes drugs also. Your Schuckstadt syndrome is post-asthma, and one asthma drug, Montelukast. Montelukast and asthma is chronic, repetitive. Asthma is not acute. It will keep on be there lifelong. Streptococcal post is acute, right? So this is an acute problem. This is a recurring and a chronic problem. The moment chronic word comes into the play, I will know that I'll have granulomas. And it's asthma. What's the WBC you'll see in asthma? Eosinophils. Microscopy will have eosinophils. Microscopy will have granulomas. The other case, post-streptococcal. What WBC? Neutrophils. I might also have broken neutrophils. Neutrophils will be there. If you remember necrosis chapter, we read karyophyresis, that is broken neutrophils. Because of this broken neutrophils, I had one more term, leukocyto, that is leukocytes, clastic, breaking vasculitis. Remember osteoclast? It breaks bone. Leukocytoclast, broken WBC is broken neutrophils. That's the other name for your microscopic polyangiitis, right? You will not see granuloma because it's an acute vasculitis. Acute problem will not have granuloma. Both are small vessel vasculitis. One is acute, one is chronic. If I have a tiny vessel in the finger or in my skin has been broken, it will result in tiny bleeding, right? That is petechiae purpura, classical for acute vasculitis. Chronic also, I'll have tissue destruction. You'll have petechiae purpura chronic also because these are tiny problems. In the capillaries of the skin, I can have a problem, right? Lung will be involved. Yes, because lung has multiple capillaries. Here also lung involvement will be there. Here, lung involvement will be acute, similar to ARDS. So we'll have an acute problem here. Acute breathing difficulty, acute hemorrhages will be there. But in Schuckstadt, it's always chronic. Here, it will be like a disease called an interstitial lung disease or pulmonary fibrosis. It's recurrent, right? Anything recurrent will end up in having fibrosis. Again, acute problem, crescentic glomerulonephritis or RPGN. What is the chronic glomerular problem? You know that. Focal segmental sclerosis, glomerulosclerosis. Same disease, the recurrence gives a different manifestation, acute gives a different manifestation. There is a possibility, even in skin, you'll have recurrent damage can result in sclerotic skin, possible still. Both are anti-MPO mediated pathogenesis. I want you to write the same pathogenesis as we discussed in vaginas. That's all. Fine. Treatment, treat the etiology. Control asthma, Schuckstadt will control. Take the drug which is causing your leukocytoclastic vasculitis, that will drop. You treat the infection, it will automatically come back to normal, right? Treatment is always treat the source. Source removal is by default the important thing. Unless and until I am not able to remove the source, obviously I can give anti-inflammatories to reduce the inflammation. Is that clear? All these three are ANCA-mediated vasculitis. Fine? Done? Any questions? We have been silent for quite some time. If you have any questions, let me know. If not, we'll go to the next topic. Next topic, we're going to talk about vascular tumors. I'm going to ask you vascular tumors because I know for a fact that you must have ignored that topic, right? Because no questions come on vascular tumors. The only vascular tumor we know is Kaposi sarcoma. Apart from the rest, everything, how we'll manage it. Hemangioma will write something, right? I'll ask questions. Let's see if you can answer me. I want you guys to answer who is online. Okay? I'm going to give you history. A very classical history can come in a one-liner or in a Viva. There is a tumor, bluish color, under the nail bed, which is painful and tender on touching. What's a tumor? It's a very, very classical history. A tumor under the nail bed, painful to touch, and also it's tender. Classical tumor. Starts with the letter G. That's a clue. Come on guys, you know this one. I gave a clue also. It starts with G. That is a tumor called as glomus tumor. Right? Perfect. The glomus tumor. Right? So glomus tumor is a subungual tumor which will be tender to touch and will be painful. Glomus tumor comes from modified smooth muscle cells which are glomus cells. The purpose of glomus cells is thermoregulation. When you are cold, your fingertip becomes colder, right? In a colder temperature because of thermoregulation, and these cells help in the thermoregulation, right? Perfect. So with respect to your vascular tumors, we divide the vascular tumors slightly differently. We always call benign and malignant only in most of the tumor, right? Here I have benign, I have intermediate, and I have malignant, right? Hemangiomas, glomus tumors are benign. Intermediate is Kaposi and hemangioendothelioma, and malignant one guy is angiosarcoma. Fine. Okay. One important thing, both these hemangioma, capillary and cavernous, both of them are non-encapsulated. Generally, for any benign tumor, we'll say it's an encapsulated tumor, right? It's the most common benign tumor in children, not all over. In children, hemangioma, very common. If you have sisters or brothers who have young kids, some of them you can commonly see reddish spots. These are hemangiomas. Need not do anything. Wait. It will automatically regress with time. The moment the kid grows, it will automatically become normal. That's all, right? It can occur in trunks, extremities. There's no association here, but most of the hemangiomas are syndromic associated. Cavernous hemangiomas. Capillary, it's not an association, it's a random thing. Cavernous hemangiomas can be seen with syndromes. This can happen in internal organs like liver. So it's a problem for us, right? Capillary is tiny capillary. Blood will be there. So automatically it'll give red color. Cavernous is a space. You must have read about cavernous sinus, right? It's a space. When there's a space, blood accumulates and stores. The moment blood stores in a space, will it be oxygenated or deoxygenated? It will be deoxygenated. What will be the color of deoxygenated blood? It will be bluish in color. So the color itself will be different. Because of the deoxygenated blood, why deoxygenated? Because I have a space here. It's a cavernous space. This is where your blood will be there. Blood will be there. It will be deoxygenated. This does not regress with time. You have to treat it by surgical removal, right? So what you'll see in microscopy, tiny capillaries, you'll have abundant vascular space along with the most important thing, fibrous septa. Okay. These images might look difficult, but again, it's very easy. Put a background, multiple tiny thing, put an RBC inside, that is capillary hemangioma. Big space, multiple RBC inside, cavernous hemangioma, right? And there's one more thing of cavernous hemangioma called capillary hemangioma called as pyogenic granuloma. This is a clear-cut Viva question. Pyogenic granuloma is a lobular capillary hemangioma. It's a misnomer. It is not pyogenic. It is not granulation tissue. Why did we call it pyogenic granuloma? Because pyogenic granuloma is again non-encapsulated. Because of that, you'll have ulceration. It will be seen mostly in the oral cavity and the nasal cavity. That's where you'll see. It's very commonly associated with pregnancy. Because in pregnancy, what will happen to hormones? Normal, or it will keep on swinging. You'll have hormonal swings, right, in pregnancy. And you know for a fact, estrogen is 1% which will proliferate blood vessels. Pregnancy, you have the entire placenta dividing. The mother should give adequate hormones for that. The same thing will have impact in the person's body also, mother's body also, right? So you'll have the same problem here. Multiple capillary will blow up in the face, nasal cavity. Where you'll have this? Because of the ulceration, can I say in microscopy, you'll have neutrophils. You will have neutrophils. And it's a capillary hemangioma. You see neutrophils plus multiple tiny capillaries. Can I think, okay, it could be a infection with the granulation tissue. Granulation tissue is nothing but capillaries, right? Multiple tiny capillaries are granulation tissue. That's a term. We call it, okay, there's a neutrophil. So it could be a pyogenic infection. It has granulation tissue forming a mass. So we call it granuloma. That's a misnomer. It's a lobular capillary hemangioma. That's all. As simple as that, right? Might not come in a long answer, 2 marks, or in a Viva. Why is pyogenic granuloma an infection? No, it's a lobular capillary hemangioma. That's it. Fine. And I started this discussion with glomus tumor. Very classical location, pain as well as tenderness. It's not just pain, because subungual, anything will be painful. You have a prick, damage, hemorrhage will be painful. Painful and tender, and a tiny mass is classical for a glomus tumor. Glomus cells are specialized cells for thermoregulation. Again, an MCQ point. Glomus cells are nothing but modified smooth muscle cells, which is seen perivascular. So what I see in microscopy is I'll have lots of small round blue cells in the perivascular location. Since they are smooth muscle cells, it's positive for smooth muscle antigen. The location and the origin is very, very important for glomus tumor. It's also a benign tumor. We do have multiple different types, glomus tumor, glomangiomas and everything. Have you gone to ENT postings? You must have read about glomus tympanum and everything. Same guy, right? So I can have in multiple places in the body, but a common location is under the finger, subungual location beneath the nails. Fine. Okay. Now let's come to Kaposi sarcoma. Before going to Kaposi sarcoma, let's make the ideal, very, very ideal crowd talk something, right? Simple questions, answer. Tell me one infection which comes to your mind as an etiology of Kaposi sarcoma. What infection is that? Etiology of Kaposi sarcoma, infection. Come on, you guys should answer. I don't want HIV here. HIV is not the answer I'm looking for. Etiology of Kaposi sarcoma. Kaposi sarcoma, the virus is HHV8 or human Kaposiform virus. Dharmishta, HIV is right. HIV is a risk factor. HIV will not cause Kaposi. HIV will add HHV8, which causes Kaposi sarcoma, right? Please do remember, HHV8 or the human Kaposiform virus is the cause, okay? Right? That's the cause. HIV is a risk factor, right? I have multiple types of Kaposi sarcoma. One, it can be endemic in Africa. There's a place where HIV is very rampant. Because of that, HHV8 is very common in the community, endemic Kaposi sarcoma, right? Or I can have HIV associated Kaposi sarcoma, like you guys said. The problem is, you and me also can have HHV8 infection, but my immunity will kick it out. When the immunity drops, be it due to HIV infection, or be it due to transplant, or be it due to age, extremes of age, elderly, like 80, 90-year-old, can have definitely reduced immunity. That also will cause Kaposi, right? So you have 4 causes of Kaposi: extremes of age, endemic in Africa, HIV associated, and transplant induced low immunity, because transplant will have immunosuppressants, right? Because of this HHV8, which will cause inflammation in the vessel, and it increases VEGF. VEGF will cause division of blood vessels by default, right? Plus, I have a viral protein which mimics cyclin D1. Okay, it's a viral protein which works like cyclin D1. What does cyclin D1 do? We read in WBC, pushes a cell from G1 to S phase. That leads to uncontrolled proliferation and a tumor. Kaposi is an intermediate grade malignancy. It's not malignant, it's not benign, it's intermediate grade neoplasm. Why? Because if the immunity improves, Kaposi will regress. That's not a feature of a cancer. HIV patient gets treatment, immunity improves, Kaposi will disappear. That's why it's intermediate grade malignant neoplasm, right? The most common side is skin and subcutis, reddish to purple. When you see this anywhere, my answer is Kaposi. Patch, plaque, nodule of red purple lesion is Kaposi sarcoma. I'll have all 3. Patch is flushed with the skin. Plaque, you can see it is little bit elevated from the skin. Nodule, definitely nodular. It's a classical thing for Kaposi sarcoma. What do you see in microscopy? It's a vascular lesion. And sarcomatous, I'll have increased spindle cell with vessel formation. Okay. One of the most important marker, remember this. Relating them with inflammation chapter. You remember PCAM1, diapedesis. The other name is CD31. PCAM1 is present in every endothelium. So a tumor coming from endothelium will be positive for that. CD34 will be positive for that. 1 will be in factor 8. 1 will be in location is endothelium. That also will be positive, right? But if you remember 31, that's more than enough. Rest are all additional points, right? That's what is about Kaposi sarcoma. Last but not least, angiosarcoma. It's the most aggressive malignant neoplasm, right? Here also common side, skin and subcutis. The only difference, you'll have marked ATP and mitosis here. Same marker here. You'll have spindle cells with marked ATP. Not like Kaposi sarcoma. You'll have very marked atypical cells. Same marker here, IHC. If I want to write one, I'll write CD31 or CD34 is a marker for angiosarcoma as well. Fine. Okay, perfect. So we know about the tumors of the blood vessels. We saw hemangiomas, capillary, cavernous, pyogenic, glomus tumors, Kaposi sarcoma, and your angiosarcoma, right? This should be more than enough for you to write even a long answer question if at all they ask you one, right? Perfect. Now let's go to the next guy. Next guy is very, very likely to come in a essay question. I'll give you a history. You tell me what's a diagnosis. A 45-year-old patient, listen carefully. A 45-year-old patient came to the OPD with crushing pain in the precordial region and he said that it feels like an elephant standing on it. And the pain is radiating to the left side of the arm. The patient was admitted. ECG showed ST elevation, T wave inversion. Cardiac enzymes are normal. What is your diagnosis? What's your diagnosis? Okay, Chitrashi started with MI. Others, Falak has gone with angina. Others, angina again. MI, angina. Okay. The answer is angina. Can anyone tell me why not MI? Because I want you to understand the difference here. Can definitely come in a Viva. It is not MI for the only reason cardiac enzymes are normal. Cardiac enzymes can never be normal in MI. It will definitely be elevated. Same history, same ECG findings, cardiac enzymes are elevated. My diagnosis straightforward, myocardial infarction. One is ischemia, the other is infarction. Fine. Okay. Marker is the point. So the ECG change will be seen in angina as well as in MI. History will be same in angina as well as in MI. Cardiac enzyme being normal is angina, reversible. It's not yet undergone necrosis. Fine. And cardiac enzymes being elevated means the cell membrane is damaged and that's definitely infarction, right? Perfect. I'm not going to talk about angina or infarction here because you know what to write there. The same pathogens of atherosclerosis. If at all there's history of MI and they ask pathogenesis, write the same ditto of atherosclerosis happening in the coronary vessels. That's all it is, right? What we're going to discuss is the post-mortem findings of MI. They'll definitely ask this in a question. Fine. We need to know gross and we need to know microscopy as well. Gross staining method is, we have something called TTC, triphenyl tetrasodium chloride. So you take the post-mortem gross, slice the heart into 1 centimeter and you pour a dye. This is a gross dye. This is not a microscopic staining. You just dip it into the dye and take it outside. If the dye, after taking it outside, if the muscle is entirely red, the tissue is normal. If it's completely pale, it is infarcted zone. If something is extremely white, it's a scar tissue because there's no perfusion at all. Old infarct. Pale is your infarcted zone. Red is normal. Because TTC, in an infarcted zone, you will have treatment of which, Hardik? You will have your LDH which will come outside, the enzymes will come outside, which will interact with the TTC and kind of reduce it and make it pale. That's all. It will not let it stain. That's it. Brick red color is the normal staining of TTC. If a reasoning why question comes, this will be the answer. Because in an infarcted tissue, the LDH which will be there outside extracellular space will kind of interact with TTC and will not let it stain there, right? This is one school of thought. I will stick to this school of thought because Robin says that. There is one more school of thought also. Let's not go into it now. Fine. This is gross. Then we'll go to microscopy. Microscopy is very easy. It's wound healing by secondary intention. That's all. If you carefully look, the first two are unique. After that, you'll have necrosis, you'll have neutrophil, you'll have macrophages, you'll have granulation tissue, you'll have scar. Exact wound healing, right? Same. The only thing is, it happens in a different timeline because here I have tissue loss. There is secondary intention. It's not primary intention, right? Perfect. Let's come to this. The first change in light microscopy will be only after half an hour. Initially, I won't have any change in light microscopy. It will be absolutely normal. You will have but all this electron microscopic findings. Swollen endoplasmic reticulum, detachment of ribosomes, your myelin figures, all of them will be there because these are all electron microscopic finding, right? Then the first light microscopic finding is waviness of fibers. Again, there are two schools of thought for waviness of fibers. One, they say that when there is more calcium, the live myocardium, which is surrounding the dead tissue, will get shrunken. That causes waviness. Or others say that is due to buckling effect. Buckling effect is very, very simple to understand. If you have not understood till now, trust me, you'll understand this now. If you have a round neck t-shirt, after some point of time, the round neck will not be round. It will become wavy. Why? It has lost its elasticity. So dead fiber will lose its elasticity. So it becomes wavy. That's all. It's waviness of fiber. That's called as buckling effect of it. Fine. Okay. Next, after 4 hours till 24 hours, the tissue dies by classical coagulative necrosis, only pink color. This is the change between primary and secondary intention. Here the tissue dies. Neutrophils does not come here. It comes only after 24 hours. Here you'll see only death, only necrosis. Then 1 to 3 days, I'll have necrosis plus neutrophils. If you want to make it a little bit more elaborate, tell that in the early part, around the first day, there'll be more of necrosis, less of neutrophils. Fine. Okay. Perfect. Next is, in the late drafts, towards the third day, the neutrophils will be a little bit more and the necrosis will kind of vanish. That's what happens between 1 to 3 days. The moment neutrophils goes, eating every dead tissue, who will replace is macrophages. Macrophage will enter the site in 4 to 7 days. Here, there will be clear cells on microscopy, and this is an application. Why do I have myocardial rupture during 4 to 7 days? I can ask a reasoning why question. Because in this time, in the microscopy, there is no necrotic tissue, no scarring, no neutrophil. I have only cells, only macrophages. When I have only macrophages, that makes it technically weak. I don't have a normal tissue, dead tissue, or a healing tissue. That's the reason myocardial rupture, be it in the free wall or in the septum, is more common during 4 to 7 days. Fine. Next, this is change it a little bit. 7 to 14 days. It's like early granulation tissue, late granulation tissue. So we'll keep it 7 to 14 days. I'll see granulation tissue. Anything beyond 14 days, be it 1 year, 2 year, I'll have only scar tissue, right? It's type 3 collagen, not 4 collagen, right? Granulation tissue will have lots of blood vessels and type 3 collagen, and the scar tissue will obviously replace to type 1 collagen. Just a question. Let's see how many of you can answer this Viva question. What will be the stain for collagen? Let's see how many of you can answer. Anyone? Stain for collagen. You guys should know the answer. What's stain for collagen? It is perfect. It is Mason. Let's see if you can find the mistake. Is it right? Wrong. Stain for collagen. Right, wrong. It is obviously wrong, right? It is Mason's trichrome. Can anyone tell blue Shizan? Can anyone tell what's the stain for what's Mason Fontana stains? Mason Fontana stains melanin, right? Okay. Mason Fontana stains melanin. Mason trichrome stains your collagen, right? Just both are Mason, so please don't get confused. Fine. Perfect. These are the microscopic findings in case of MI post-infarction. Fine. Perfect. If you want to draw diagrams, again, these are very simple line diagrams. It might look pink and blue, but it's very, very simple to draw. First, just draw fibers with your nucleus. That's all. Second, please draw a little bit of wavy fibers. That's all. You just draw wavy fibers. More than enough. Third, pure pink areas. You can put on and off neutrophils here and there. There's pure coagulative necrosis, right? Fourth, I'll have lots of neutrophils plus necrosis. 4 to 7, I would want you to draw more and more of clear areas because lots and lots of macrophages will be there. Then I want blood vessels with RBCs, that's granulation tissue. Finally, I'll have pure scar tissue. Just wavy collagen, that's what will be there after 14 days. Fine, perfect. Reperfusion injury. It's also a very common question. Reperfusion injury might come in a 5 mark. I've seen papers which is asking reperfusion injury in 5 mark. If you want to write for 5 mark, first you have to tell us what is reperfusion. Please, if it's a very short answer, you know, but they've asked for a 5 mark question, give a pretext to it so that the answer becomes appropriate. So for us to know reperfusion, we need to know about critical time. The way we treat myocardial infarction is by reperfusion. That's all. Either therapeutic by pharmacology, you have drugs, streptokinase, altiplase, or you do a stenting procedure, percutaneous coronary angiography, right? So there's a critical time for reperfusion. within 1 day, within 2 days. There's a critical time for reperfusion, right? You will know from your medicine what's the critical time for reperfusion for brain and heart. For stroke, it is 4.5 hours. Within 4.5 hours, I should reperfuse. What will happen if it's done beyond the critical time, right? If reperfusion is done beyond critical time, that becomes counterproductive. That becomes problematic here. This is done when we have found the critical time by doing lots and lots of studies here. That's all. Okay. So what happens is, the first thing is there will be fresh reactive oxygen species which will come inside in a tissue who is dying. A dying tissue will not have antioxidants. I won't have the enzymes to remove them, right? Because it's dying and it's dead, right? So this will cause more damage. That's one of the important cause, right? Second, again, a fresh blood which is pumped into a dying tissue will have fresh calcium. Calcium is seen extracellular, right? So when the fresh calcium comes, it can obviously trigger more cell death. You know that calcium is one of the important ions to trigger cell injury or necrosis, irreversible death, right? That is also there. Fine, perfect. Then third, beyond 1 hour, beyond 2 hours, what happens is you will end up in having leaky blood vessels. Let's say this is heart. Muscle dies because of no blood supply there due to MI. In the same place, I will also have capillaries, no? They also will die, right? So that is called an microvascular damage. So this microvascular injury will happen when I do it beyond critical time. So this microvascular injury, what is the problem? I have leaky blood vessels. What it will do is, this microvascular injury will increase WBC exit into myocardium. Imagine I'm having a blood vessel which is leaky. I'm introducing new blood. WBC will go outside. The moment it goes outside, it will get activated, cause more damage by creating reactive oxygen species, right? These are the reasons why which I have reperfusion injury. So if I do it beyond critical time, I definitely will be ending up in causing more damage than being helpful. So what will I see in microscopy? In microscopy, the primary reason for that is increased calcium. The moment calcium enters into a muscle, it will cause contraction. Here, this excess calcium here will cause hypercontraction. That's what is going to happen here. I have excess of calcium here, which causes hypercontraction of the muscle fibers. Once you have hypercontraction, what will happen? It will be more pink in color, right? So which causes eosinophilic contraction bands. It will be bands like this, called as eosinophilic contraction bands. That's diagnostic of reperfusion injury, right? Give a pretext of what is reperfusion, why it is required, give a pretext of what is critical time, and then talk about injury. Will this injury happen when I give before critical time also? Yes, but there benefit is more than the damage. But beyond critical time, damage is more than the benefit. That's why we had the concept of critical time. And also write what you see in microscopy. Clear? This alone can come in a 5 mark. Do remember them. Fine. Perfect. Just a quick 2 mark notes. We'll quickly wind up. The vegetations, right? Vegetations, I'm sure you know. There are 4 vegetations: rheumatic heart disease, non-bacterial thrombotic endocarditis, Liebman-Sachs, and infective endocarditis. What are the premise we are going to talk on? Where do I see them? What are they made of? Are they infective? Are they destructive? That's all. And obviously the conditions we see them, right? Okay. RHD, or also called as verrucae, because they are very tiny, looks like a wart. Verruca vulgaris. It is seen along the lines of closure or the edges of the valve, right? See, these are the lines of closure. There's a valve, right? There's a valve leaflet which is closing. Along the lines of closure, you see them. Okay. It's a sterile vegetation. Remember this, because whenever you think about rheumatic heart disease, what comes to your mind? Streptococcus. Here it is not streptococcal damage. It is immunological molecular mimicry based damage. So it is sterile vegetation. It is not infective. Okay. Next is NBT. NBT is the short form for non-bacterial thrombotic endocarditis. It's non-bacterial. Sterile, obviously. It's there in the name. Thrombotic. What I see? It's thrombus. They are also seen along the lines of closure. Again, they are tiny, less than 5 mm. Along the lines of closure. It's thrombus. So where do you see them? Any prothrombotic state, I can see them. In your virtuous triad, you must have read about a lot of prothrombotic state, right? Can anyone tell me one prothrombotic state? apart from the examples given here. Any terminal stage of cancer will have DIC. Okay. Apla syndrome, I'll have it. Any cause of DIC, I'll have it. Factor V latent mutation, you'll have it. Any prothrombotic state, whatever you know under the sky, there is a chance they can have non-bacterial thrombotic endocarditis, right? Again, a reasoning by question. Previously, we were calling them as marantic endocarditis. Why? Though we don't call them marantic endocarditis, previously we were calling them, right? Marantic endocarditis because they thought it is seen in marasmus. What is marasmus? The protein energy malnutrition, right? That's a wrong. It's a misnomer. Why it is wrong? They thought they are very thin patient, right? They said, okay, it's marasmus. It is not marasmus. That is actually cancer cachexia. You remember cancer cachexia? An extremely terminal stage cancer patient also will be cachectic like a marasmus patient. They looked at the patient and they said it's a marasmus related endocarditis. It is not marasmus related. It's a thrombotic related endocarditis, which also happens in terminal stage of cancer. Fine. Perfect. Then your Liebman-Sachs. Liebman-Sachs it's only an hype endocarditis, right? You don't see them often. It's seen in SLE, but it's seen in both the atrial and the ventricular side. It's seen on the valve leaflet, not in the lines of closure. It's on the leaflet. If you can look, the diagram also has changed to the edges of the valve to the leaflet here. Okay, it's in the leaflet. Antigen antibody complex, it's simply seen in SLE. Infective is the outlier of all. Large and fragile, infective, destructive, and it can undergo embolus. It can cause abscess, it can undergo embolus, which causes more and more damage, right? It's one of the outlier which can destroy everything, which can go outside, which can have complication of myocardial aneurysm, brain abscess, everything, right? That is infective endocarditis for you. Fine. Okay, perfect. These are the 4 different types of endocarditis which can come in an exam. Fine. Or in a Viva, they might ask you at least name a few types of valvular vegetations. That's it. Okay, done. We'll look at cardiomyopathy later. Before that, we'll go to a few of the lung lesions, and then we'll, if time permits, we'll come back to cardiomyopathy. Fine. Got it? Okay, before going to emphysema, I'll ask you a few questions so that I'll know where you stand, right? Because I'm sure that cardiovascular pathology might be not a favorite topic, but lung pathology, most of you must have read it, right? Can anyone tell me one of the most common cause of emphysema? One most common cause of emphysema. Thank you, Ali. Do well. One common cause of emphysema. The common cause of emphysema by default is smoking, right? I don't know why you guys are thinking so much. It's by default cigarette smoking, right? Perfect. So emphysema, we divide them anatomically. What are the types of emphysema you know? Whatever comes to your mind. Amazing. Smoking is the only cause of emphysema. Yes, I do have alpha-1 antitrypsin deficiency also, right? You have centriosinar, you have panacinar, you have paraseptal, and then you actually have one more type of emphysema person, irregular emphysema. Irregular emphysema is not seen clinically. You also have it, I also have it. Tiny damage in the lung. That damage associated alone, you'll have emphysema. Fine? Okay. Saurabh gaming later on. Fine? You'll have 4 different types of emphysema theoretically, but centriosinar, panacinar, paraseptal, clinically, irregular emphysema is seen mostly in autopsies, not clinically viable. Fine? Okay, perfect. It's one of the examples of COPD. Fine? Yes, you are absolutely right, Jijan. I did the same thing. I said the same thing, right? Okay. Emphysema, the first definition, I want this. It's a permanent destruction. It's not reversible at all. It's a permanent destruction distal to the, not bronchioles, distal to terminal bronchioles. That is also very, very, very important. It's an anatomical classification. That's all. Entire COPD is anatomical classification, right? It's a terminal bronchioles. Beyond that, permanent destruction of the alveolar wall is emphysema. That's all, right? Here, the elasticity will be lost. So, alveolar cannot relax back normally as is used to, right? So, what happens is, smoking is by default the most common cause. Smoke will cause degranulation of neutrophils. Neutrophil's granule content is elastase. This granule content is the one which destroys the lung elastic tissue. So the loss of elasticity, which results in overinflation and air trapping. This is what happens in emphysema. But you and me have a protective guy, which is alpha-1 antitrypsin or antiprotease. The moment elastase comes outside, antiprotease destroys them. That's why we inhale smoke, not due to smoking, environmental smoke. We don't have emphysema because we are protected. So there are two causes of emphysema. One, when you abuse the level of alpha-1 antitrypsin, I cannot protect because you're a chronic chain smoker instead of having emphysema, or the enzyme is defective. This is an autosomal recessive inheritance. Enzyme is defective by default. That also will result in emphysema, right? Classification of emphysema again is anatomical classification. Okay, so here I have centrious nerve, where only the center part of the SNA is gone. This is gone. Let's say the distal part is normal. Centrious nerve. This is the most common type of emphysema. Again, I am talking about clinical subtypes, right? Center part of the SNA is gone, caused by smoking, and it's mostly seen in the upper lobes. A simple explanation: smoke goes up, so involves the upper lobes of the lung most commonly than the lower lobes. Pan-acinar or pan-lobular. Entire SNA and entire lobule is gone. Seen in alpha-1 antitrypsin deficiency, seen common in lower lobes. This is the clue. If you have to give a clinical one, this is a clue, right? Amazing, Sasu. All the best. Do your third year as well. Okay. A family history present, and there's a associated liver damage because hepatitis is also very common in alpha-1 antitrypsin deficiency, right? And even without a history of smoking, it can damage lungs because environmental smoke is enough to cause damage to the lung in this particular condition. That's your pan-acinar emphysema. Next we have distal acinar, para-acinar, or we call it bullous emphysema. While the distal part of the SNA is destroyed, here also is due to smoke only, right? The dynamics of smoke is different, that's all. Here also is due to smoking related damage which causes distal acinar. If the distal part of the SNA is gone, example like this. So here the pleura is here. That's why we call it paraseptal, close to the pleura. Distal part is gone, it's ballooned up. If there's a trauma or spontaneously also bulla can rupture. You remember the introduction scene of Good Doctor, the airport scene. Bullous emphysema, it ruptures, that's all. The moment it ruptures, the air enters the pleural space. When I inspire, because it's ruptured, air will go inside here into the pleural space. When I expire, air will collapse, the bulla will collapse because that's negative pressure, no? During expiration, there's no air entry because the bulla collapses. So with every inspiration, every cycle of respiration, air keeps on accumulating in the pleural space. We call them a tension pneumothorax, which is an emergency, right? How will you identify tension pneumothorax? One of the most important thing is absent breath sounds, a classical clinical finding. Okay. Yes, X-ray will give me a clue. I'm not denying that at all. But taking X-ray, getting the report, diagnosing, it will take at least half an hour to 45 minutes in our country. Auscultation with tracheal deviation, with a classical history of sudden onset of breathlessness, diagnostic of tension pneumothorax, put an intercostal tube drainage as early as possible, remove the tension. If you don't remove the tension, it will compress and cause atelectasis. That's what happens in case of tension pneumothorax, right? Perfect. And central emphysema and pan-acinar, if you want to draw a diagram, draw small dilated and everything else normal in central nerve, right? And everything dilated in case of pan-acinar emphysema, as simple as that, right? And both of them are classical case of COPD. There are two names for COPD. One is pink puffers, one is blue bloaters. What is emphysema? Pink puffers or blue bloaters? What do you guys think for emphysema? Are they pink puffers or are they blue bloaters? Emphysema is, they're also called as pink puffers. Clinically, COPD, difficulty in breathing, breathlessness, increase in the respiratory rate, tachypneic, everything, and they have a pursed lip breathing also. Okay, pursed lip breathing because that increases the pressure. It increases the pressure so that the alveoli can expand and it can relax. Pursed lip breathing, classical emphysema, right? Chest X-ray, you will see hyperinflated lung fields. That's what we'll see in case of chest X-ray in case of emphysema. It will become more, right? Clinical examination, this hyperinflated lung fields will cause barrel-shaped chest. That's a classical clinical examination for emphysema, right? You are right, Sijan. Fine. And like I said already, there's a type of emphysema called an irregular emphysema. I'm not mentioning it, and mostly I won't mention it in any lectures because it's clinically irrelevant. But there's a entity. You have an URI, right? Maybe you must have had COVID also. I also had COVID. My lung is damaged. That part of the damaged lung will have tiny alveoli sac which are destroyed. I can't do anything to that. Will it cause me breathing difficulty? No, it won't. I have this big lung, 1 or 2 dots here is fine for me. Right? So this is sporadic damage to lung parenchyma. It's not clinically relevant, but yes, I can see them in postmortem by default. That is irregular emphysema, right? Perfect. So that's about one of the COPD, which is emphysema. Fine. Okay. Next thing what we're going to talk about is pneumonia. Did Anisha ma'am talk about pneumonia in your CVS infections? She must have definitely talked, right? 3 times. Your lucky is done. So you come back here to give COVID a nice send off, right? Make sure you read amazingly well and you'll try to control all the future pandemics. All the best. Okay. When a question like pneumonia comes, first and the foremost thing, don't say that, okay, it's a pathology exam, it's a pathology topic, I'll write only from Robbins or whatever book you read. There are overlapping topics by default with path and microbiology, right? Definitely. Use both of them. When they ask in microbiology also, use the pathology knowledge if it's relevant. If they ask in pathology also, use the microbiology knowledge if it is relevant. It is very, very important because at the end of the day, I'm going to treat a patient who is having a disease. I'm not going to treat a pathology patient, microbiology patient, medicine patient, ENT patient. We're going to treat patients, right? There are lots of overlapping subjects. Hypersensitivity, by default, is overlapping. Immunology is overlapping. Use that judiciously so that you will have good amount of content to write, right? So what I'm going to talk about in pneumonia is the stages of typical pneumonia and what is atypical or interstitial pneumonia. Classification, I'm not going to talk. I feel microbiology classification is much more accurate than pathology because we classify based on organisms. We classify based on the place we get the infection. Okay, community acquired, nosocomial, hospital acquired, right? That's how we classify them, right? So I leave the classification there, and microscopically we call it typical, atypical, interstitial, alveolar. This is how we classify pneumonia, right? So typical lobar pneumonia stages, I don't know why they ask. Still they ask you, right? If I am the examiner, if I have the liberty, I want to remove the stages of pneumonia from Robbins. Because you don't see the stages these days at all. It's a pre-antibiotic era. But still we read, okay, we have congestion, we have red hepatization, gray hepatization, resolution. We don't have these stages at all these days. Because the moment you have an URI, you put an azithromycin. Where will the stages happen? It will not happen at all. And again, you need not memorize the stages. Simple. Pneumonia is an acute inflammation, right? Vasodilatation, increased vascular permeability, coming back to normal. That's all. If it's worse, complication. That's all. It's a stage of acute inflammation. That's all. So within 24 hours, the vasodilatation phase of the inflammation results in your congestion. It's a congested lung. That's it. So here, the symptoms will be totally non-specific. It is not lung related. You won't have a symptom of cough. You won't have a symptom of sputum production or breathlessness in the first stage. You'll have fever. That's all. It'll last for 24 hours. Second day onwards, then you'll have localizing problems because the congested lung now will cause increased permeability. That's what acute inflammation, right? Here, 2 to 3 days. Again, this timing is purely in the pre-antibiotic era. Fine. Okay. So the soft lung becomes firm because of the increased vascular permeability. The moment I have increased vascular permeability, I'll have exudates in the alveoli. When there's exudates in the alveoli, there'll be decreased air-gas exchange. Only till the alveoli has air, the lung is soft. The moment it has fluid or WBC, lung definitely becomes firm, right? So this exudates in the alveoli here. What I'll have is, I'll have both RBC and WBC here. That's the reason I have red hepatization, right? Real student, मेरा हिंदी थोड़ा खराब है. अगर if you have any doubts ना, please do ask me in Hindi. I'll reply slowly in English. ठीक है? Fine. Okay. So we have increased vascular permeability. Fine. So here, this non-aerated soft lung is what we term them as consolidation. If in a Viva they ask what is consolidation, right? they tell it's a non-aerated lung. That's all is consolidation. I can see consolidation on X-ray. You can use them in auscultation, bronchial breathing. You can use them in percussion also. Clear? That's it, right? Symptom, here I'll have classical lung-related symptom. You'll have cough, you'll have expectoration. Can anyone remember your microbiology and tell me the color of sputum? Hi Saurav, all the best. Color of sputum in microbiology in case of a classical typical pneumonia. You must have definitely read this. You must have read it. Classical is rusty brown sputum. Okay. Classical sputum of pneumonia is rusty brown sputum. You see this in any question. It's a bacterial pneumonia. This is a clue. Red currant jelly sputum. Klebsiella pneumonia. Right? There are different colors of sputum that will help me to sometimes identify the organisms. But classical rusty brown sputum is for a typical bacterial pneumonia. Do remember that. Fine. Next. After the increased vascular permeability, RBC came outside. RBC has no job in acute inflammation. They'll be destroyed. So WBC will retain, right? So what will happen? I'll have X-rays, but predominantly WBC based. I'll have a little bit of fibrin also will keep on increasing. So it's a fibrinous exudate. It's still hepatization because it's firm like a liver, right? It's firm like a liver. Shali, it won't be yellow in color. It'll be mostly rusty brown in color, right? Yellow color is more for an URI. Upper respiratory tract. The moment it goes to lungs, it'll have the rusty brown nature. Fine. Okay. Coming back to this. Here also I'll have consolidation will persist. The red color will be gone because RBC will be lysed, right? So we call it a gray hepatization, right? Symptoms will remain the same as your red hepatization. Here also you'll have sputum. Here also you'll have expectoration. Everything will remain the same, right? Beyond 6 days, what happens? If your immunity is good, okay, if your immunity is good, what happens is it'll get digested and cleared, may have a scar tissue, and your symptoms will return to baseline. Okay, will return to baseline. Zishan and Shali Patel, right? Sahil Patel, sorry. See, yellowness to a respiratory secretion is due to purely neutrophils, right? When an organism is capable of invading into a lower respiratory tract, it is a little bit more powerful. So it causes damage to the cells. The moment cell debris come, you remember your, what's that guy's name? Lipofuscin start to come. It's a wear and tear effect, right? That's why you have the brownish tinge. If it's not involving the lower respiratory system, you'll have predominantly dominated by neutrophils because there's no tissue damage. Neutrophils kills them. That's where you have pure yellow color sputum. Fine. Okay. Sahil, sorry. Let's come back to this. That's the reason for the rusty brown sputum. Fine. So these are the 4 classical stages of typical lobar pneumonia. If everything goes good, you will have a completely normal life. If it doesn't go good, I can have complications. Very virulent organism, right? It'll be destroyed. Why cell damage? Real students, simple. Organism will go and destroy the cells because they are very virulent organisms, right? See here, it's destroying the entire lung. That's why I'm having an abscess here. Whenever there's an abscess cavity, my history changes. What happens here? You will start having foul smelling sputum. It's an abscess cavity, so you'll have a good amount of sputum, copious amount of foul smelling sputum, classical for lung abscess, right? Because lung abscess will have more of anaerobic infection also, okay? It can extend from pleural space. It can go from the lung to the pleura, can become pyothorax, can also have pleural effusion. That also can happen, right? Next, I can have completely destroyed fibrosed lung. Like COVID, most of the problem in COVID was fibrosis, right? Bacterial pneumonia also can cause fibrosis by default. Worst case, it can disseminate. When from lung, it goes into the blood circulation. I'm going to call it sepsis. The moment it reaches sepsis, not just brain, it can go to any part of the body, right? It can disseminate to any part of the body. The reason why we are more worried about brain is it's more damaging than having a fingertip infection. That's all. I can have all these 4 combinations, right? I can destroy the lung, can go outside here, okay? And I can have fibrosed lung, or I can disseminate throughout the body, fine? Sahil, every lung problem might have sputum, okay? COPD will have sputum by default. Asthma also has expectoration by default, right? Because it's the dynamics of the air and the mucus is not normal. By default has sputum, right? The color might not change that, that's all, right? Now, let's come to atypical pneumonia. One thing I want you to remember in atypical pneumonia is the organisms are intracellular, like viral or atypical bacteria. Mycoplasma is a classical example of atypical pneumonia, right? Okay. It's minimal. Sputum is not the primary presentation for emphysema. What I would say is like breathing difficulty is a primary presentation. Yes, they will have cough and sputum production also. Minimal sputum production will be there even when you have a after cells, right? So that's not the primary presentation. That's it. Fine. Let's come back to this. Intracellular organisms. Any intracellular organisms. The most common cause by default is mycoplasma. This is where I said in your microbiology you must have read a list of organisms. All of them can be written in pathology exam also. Viral pneumonias are atypical pneumonias. COVID is an atypical pneumonia, right? We also call them interstitial pneumonia because they don't damage the alveoli, they damage the interstitium. Real student dissemination routes is simple. No, sir, from the lung, the moment it enters the lung capillary, it can go anywhere to the body. It's in the blood circulation. That's why we call it sepsis, right? So it can go anywhere in the body via the blood. That's the route of dissemination. Okay. Symptoms here are dry cough. Again, the primary reason, it does not involve the alveoli, it involves interstitium. Lymphocytes, not neutrophils, because they are intracellular organisms. Neutrophil does not affect intracellular organism. It's always lymphocytes. That's why in TB, we have lots of lymphocytes. Virus lymphocytes, they are intracellular, right? And X-ray finding will have ground glass opacities. Okay. What happens here is, once I inhale the organism like mycoplasma or a virus and everything, fine. Okay. We'll discuss about that in some other session, right? We'll continue with lung pathology now for now, Kushal, right? Endothelium will have damage, right? So the moment you have an organism which is entering the lung parenchyma, atypical organisms, which will not stay in the alveoli, what happens is they escape to the interstitium and they affect the interstitial cells. We have tiny fibroblasts there, right? That will be affected. The moment interstitial cells are affected, the lymphocytes come to protect them. Okay. Most of the time, I don't have much of trouble because virus is self-limiting. All of us had COVID, right? Self-limiting, majority self-limiting. Yes, minority will have a problem, right? Majority self-limiting, not much. Parth, to pass an exam, yes. To understand, might not be. That's a very honest answer from me, right? If it complicates, if it's not resolved, in COVID, we have complication. In mycoplasma also, we can have complication. Complication happens the moment it damages endothelium. Endothelium damage is the reason for complication. Fine. Okay. And once the endothelium is getting damaged, what will happen? It will undergo something as ARDS. COVID also the complications is ARDS, right? I'm not talking about ARDS now. Endothelial damage is the starting point of ARDS by default. You can write this as a complication. Atypical pneumonia can also have it, right? See, most important thing is this atypical pneumonia need not be admitted. They can be treated on an OPD basis. Fine. So we would say that this is also dubbed as walking pneumonia. No use for these names, but these names do exist, unfortunately. Atypical pneumonia, generally, these are keywords. You'll have dry cough. Atypical pneumonia, in the microscopy, what will happen is the alveoli will be mostly clear. That's very, very important. Okay. Alveoli will be mostly clear, right? Mostly will happen in English. I don't know Hindi so fluently. That's the reason I'm talking in English. Fine. Apologies for that. Okay. So when the alveoli is clear, you will have interstitial infiltration of lymphocytes. That will be the microscopic finding and a clear alveoli. I can extrapolate this to the radiological finding also. Imagine this is an alveoli. This is an alveoli. This is an alveoli. This is an alveoli. This is an alveoli, right? In between the alveoli, all the interstitium is having lymphocytes. So there are cells in the interstitium and the alveoli is clear. So when I do an X-ray finding, can I say I will not have a very clear space. At the same time, I won't have an opaque space. I will have only a ground glass appearance, like Khan said. Ground glass is the classical glass, what you see in the ICU door, right? Translucent glass. It's neither clear like a normal lung, nor consolidated like a typical pneumonia. It has the ground glass opacity or the reticular opacity that's classical for your atypical pneumonia. Fine, because of the alveoli being clear. Fine. Reasoning why question, why there is ground glass appearance in atypical pneumonia? The answer is clear alveoli with involved interstitium gives it a ground glass appearance in atypical pneumonia or an interstitial pneumonia. Fine, perfect. So these are few things with respect to pneumonia. Any doubt in pneumonia? If yes, let me know. If not, we'll go to the next topic, which will be anthracosis. Sorry for taking much of your time. We have few more things. We'll talk about anthracosis. We'll definitely talk about asthma, though I'm sure that you are experts in asthma. And also we'll talk about lung cancer. Fine. Okay. You have amazing teachers there also. I won't want to discriminate them, Sahil. Okay. Perfect. Done. Let's go to the next topic, which is pneumoconiosis. I'm going to talk about coal workers pneumoconiosis. I'm going to talk about silicosis a little bit, and I'm going to talk about anthracosis. Fine. So there is a spectrum of pneumoconiosis, right? Pneumoconiosis can come in a long answer, might come in a long answer, right? I'm just going to ask you a few questions. Let's see if you can answer them. Whatever I'm going to talk about, I'm not going to talk about the pathogenesis, because pathogenesis is common for every pneumoconiosis. By default, it's common for every pneumoconiosis. Fine. Can anyone tell me what determines that, okay, this particular structure, this particular chemical or this particular dust will go and cause pneumoconiosis? What are the factors which will cause pneumoconiosis? Anything which comes to your mind? There are few factors which determine, okay, this is going to damage the lung. Okay, this is not going to damage the lung. What are they? Real student, it's because of the refractive index, right? The refractive index, when the light passes through the air, the refractive index changes. If you have an oil, the cedarwood oil, it will maintain the refractive index, so it improves the clarity. That's all. Great. The one is critical particle size. Amazing. Anything else apart from the particle size, Siddhi? So if they ask about pneumoconiosis pathogenesis, there are few things which is required by default. We have to talk about them, right? The first one is the particle size. Fine. The particle size by default determines, it will definitely may involve the lung, may not involve the lung. The solubility of the dust, beautiful. That also will definitely, there's a possibility for it to determine may involve the lung or may not involve the lung. Anything else apart from that? And what is about the particle size? What size of the particle will involve the lung? Small, big, any distinction that, okay, this will involve the lung, this will not involve the lung? Anything like that? Yes, no, maybe? Duration, definitely. Occupation is the one which causes the problem, right? I'm talking about the particle size. Is there any particular size of the particle? Okay, fine. Generally, particles of 1 to 5 micron size are the one which will stay in the alveoli and they will cause a damage. Particles which are more than 5 micron, my cilia will push him out and will cough it out. Particle less than 1 micron, Chitrashri, it will get dissolved. It will escape the alveoli. It will get dissolved into the blood circulation. I'll excrete them. That's one, right? Second is dust retention. The dust retention is like how much is going to stay there. That's primarily based on the dust concentration. If you're working in a place which does not have good amount of ventilation, obviously it's going to be a problem for us, right? This is equivalent to the concentration in the dust, concentration in the place where they work. That's based on the work conditions in where they work, right? Particle solubility is very, very important, right? Smaller particles, fine. If they are highly soluble, they cause rapid onset injury. Large particles which resist disintegration, right? They stay in the lung for years and they cause chronic damage. The solubility, if they are rapidly soluble, they might cause acute damage, and there are less soluble ones, they stay in the lung, which will cause chronic fibrosis. Okay, these are few things which I want you to remember. Fine. And additional problems. In addition, if the person is a tobacco smoker, in addition the person has some other COPD, some other lung problem, it will definitely cause more problems, right? Fibrogenic potential of the dust, primarily with respect to silica, it matters. Other things might not matter much, fine. Whatever said and done, this is the pathogenesis for every pneumoconiosis, right? So all the pneumoconiosis, ultimately what's going to happen? The particles settle in the alveoli. The moment particle settles, my macrophages will eat. Can macrophage destroy a silica? Can macrophage destroy a coal? Can macrophage destroy asbestos? They cannot. They won't, right? So because of that, they will get irritated and they will become activated macrophages. You know what will happen when they become activated macrophages? They will end up in having a granuloma formation. Here, primarily will have non-necrotizing granuloma formation. But the problem is, pneumoconiosis is not a granulomatous disease. Okay, it's a fibrosing disease because this granuloma is not a one-time event. The person is working in a coal mining industry for 10-20 years. Every day the particle comes inside again and again, right? So again you'll have the particle coming inside. Every single day the particle will come inside. Recurrent damage will end up in having fibrosis by default. Pneumoconiosis are classified under fibrosing disorders of the lung, which comes under restrictive disorders of the lung, right? That's what happens in case of pneumoconiosis. If they ask about asbestosis, don't write, okay, serpentine particles, amphibole particles, and plaque mesothelioma. No, introduce this. If they talk about coal workers pneumoconiosis, write the 3 different types. This is the pathogenesis. For everything, pathogenesis remains the same. The risk factor, coal mining industry, glass blowing industry, your shipping industry differs. The particles differ and the outcome might differ, but pathogenesis remains more or less the same, right? Perfect. Now let's go to this guy. In coal workers pneumoconiosis, we have 3 things, right? Okay. All the best real student. Do well next time. This time as well. Fine. We have anthracosis. We have simple coal workers pneumoconiosis. We have complicated coal workers pneumoconiosis or progressive massive fibrosis. Anthracosis, it can be seen in you and me. If you're an urban person, you smoke, you'll have anthracosis. What will I have gross? I'll have just black pigments. There'll be no nodules here. Just black pigments in the entire lung. You must have seen in movie theaters, Mukesh's lung, that's black pigments in the lung, right? Classical. Microscope will have pigmented macrophages, no granuloma. No granuloma means no tissue destruction, mostly normal. Okay. Here, simple coal workers pneumoconiosis, 0.1 to 1 centimeter nodule. Non-necrotizing granuloma, altered, reversible, but it can progress to irreversible also, right? If I stop the exposure, it will contain. If I continue the exposure, it will definitely progress, right? Complicated coal workers pneumoconiosis, anything more than 1 centimeter to 10 centimeter, it will cause massive fibrosis. You'll have extensive fibrosis. Non-necrotizing granuloma is not the predominant feature here. Here also lung function is altered and it's irreversible. Even if you stop the person going from the mining industry here, it will not come back to normal, right? Those are 3 steps of coal workers pneumoconiosis, right? And there are 2 types of coal particles. We have an anthracite coal, we have bituminous coal. Okay, anthracite coal is the one which is seen in the mining industry. It causes coal workers pneumoconiosis. It never causes lung cancer. There's an error here. There will be no increase in risk of coal workers pneumoconiosis in bituminous coal, which comes with firewood cooking, right? That's why we move to LPG. This causes lung cancer. These are 2 different types of coal. What I see in microscopy is totally based on the stage. Either I have a black color in the hilar lymph node and the lung, or you have a non-necrotizing granuloma, or you have a fibrosis based on the place. That's all. Fine. Okay. Done. Silicosis. This is the most common pneumoconiosis in the world. Fine. See, real student, what I meant there is, let's say the patient is in second stage, okay? They have stopped going into the factory. It will not progress anymore. It will stay there as such. That's all. This tiny damage, what happened, remains as a damage. It will not progress. But when the person continues going, it will move to the next stage. When they're in the third stage, that is progressive massive fibrosis, that time, even if they stop going to the workplace, it will still progress and will kill the patient, or will result in respiratory failure by default. That's the difference. I hope you understood that. Fine. Okay. Done. Silico is the most common worldwide pneumoconiosis seen in glass workers, right? Few clues: upper lobe involved, non-necrotizing granuloma, dense fibrosis, quartz. I think Shijan said something about fibrosis, right? Fibrogenic later. Quartz is the extremely fibrogenic variant of silica that can cause problems, and eggshell calcification in the hilar node is a classical finding because silica can damage and go to the subcapsular sinus in the hilar lymph node, destroy everything there, cause necrosis and cause calcifications, right? Yes, Ishan. The progressive massive fibrosis, that's the reason it will be progressive. Okay. Perfect. So in the lymph node, the silica goes there, goes to the subcapsular sinuses. The sinus macrophage will be damaged and the calcium will get deposited in the subcapsular location. That's why when you take an X-ray, lymph node will be clear, but the periphery alone will be calcified. So we call them an eggshell calcification. Like an eggshell, only the periphery is calcified here, right? Okay. Silicosis, there is an increased risk of lung cancer without fail. Silicosis, since the macrophages are destroyed, can I say if macrophage does not function properly, lymphocyte will not function properly? Because macrophage and lymphocytes are partners in crime, right? So because of macrophage destruction, lymphocyte function reduces, cell-mediated immunity reduces. Because of that, silicotuberculosis is a big issue. You should never forget writing about silicotuberculosis, and obviously risk of lung cancer, you will remember it, right? Silica nodule might result in chronic interstitial lung disease or lung failure. It can cause fibrosis of the entire lung, might result in respiratory failure. The patient might require a lung transplantation, right? That will be the outcome in case of silicosis, fine? A real student, it will be in the Telegram group of PW, or if not, please ping me here. I'll put in the WhatsApp group here. If your friends are in the group, I'll give it to them. Please get it from them, fine? Asbestos fibers. Asbestos seen in ship manufacturing industry, shipwreck industry, and also can be seen in insulation industry. Insulation things, they use asbestos. These are all the manufacturing places. It won't affect the people who are working in Navy, right? It won't affect the people who's there in ship. It will affect the people who manufacture them, because that's why we have the dust, right? We have two types of fibers, serpentine, amphibole. Serpentine is, as the name says, like a snake. They are malleable fibers. Malleable fibers is used in production because I can change to any shape I want, right? So it's suitable for industry, but there is less pathogenic. Why? They can escape the alveoli and go into the lung circulation. Not much of problem to the lung. Amphibole is not malleable. I cannot bend them, it will break. Okay? So it's not malleable. It will be rarely used in industry and they'll be more pathogenic. Fine. Ranjan, PW method as my lectures. You can go and have a look at that. Fine. There's something good for us. Something which is very commonly used is not killing as much. Something which is very rarely used is actually more pathogenic. When asked only about asbestosis, here is where I want you to write the pathogenesis, what you have discussed, right? Then the spectrum of disorders. Pleural block is the most common finding, and mostly they are incidental finding. What's a block? Irregularity on the pleura, like atherosclerotic block, right? So there'll be slight irregularity of the pleura. In the mediastinal surface, in the basal surface of pleura, you'll have slight irregularity. On an X-ray, you can see them with pleural thickening. That's the way you identify them, because they are not symptomatic at all. You can result in pleural effusion, interstitial lung disease, which is fibrosis, and also lung cancer. You must have definitely seen lots of lung cancers. Related question. The most common carcinoma is by default lung adenocarcinoma. Mesothelioma is a very specific cancers. Fine. Real student, for any sturdy places where I want hard fibers, they use amphibole, like the base of the ship and others. Insulation industry, construction, they use more of your serpentine fibers. Fine. It's a very rare condition, mesothelioma. Malignant mesothelioma happens very late in life. Whatever may be the spectrum of the disease, in microscopy, I might see the asbestos fibers or the ferruginous bodies. So asbestos coated hemocytin deposit, we call them ferruginous bodies, and these are perspiration blue positive. When you see ferruginous bodies, it doesn't mean it's lung cancer, it doesn't mean it's mesothelioma, it doesn't mean it's pleural effusion. It means this patient is exposed to asbestos, that's all. The patient could be completely normal or having a cancer. This is not diagnostic of anything, it just indicates initial exposure to asbestos fibers. That's it, fine. Okay. It's dumbbell shaped, they also call them dumbbell shaped inclusion bodies, fine. So these are with respect to your pneumoconiosis. We know the common pathogenesis and also we had a quick overlook of rest of them, fine. Okay, great, Shishan, fine, perfect. Now, asthma is something which I don't want to take. Since I want to cover it, I'm just covering it. You guys know almost everything with respect to asthma, right? Let's not go into the chart. I will ask you questions. You guys are going to tell me about it, fine. Asthma, what's the type of hypersensitivity? Anyone? Jishan, real students, who are the Siddhi, who is online? What's the type of hypersensitivity in asthma? Classical type 1 hypersensitivity. If it's type 1 hypersensitivity, which WBC is involved and which immunoglobulin is involved? Eosinophils and Ig is involved by default, right? If it's a type 1 hypersensitivity reaction, it's an immediate hypersensitivity reaction, right? If you look at the pathogens of type 1 hypersensitivity reaction, do we have any phases? Do we need sensitization? Yes, no, maybe. Definitely we need sensitization. Without failure, we need sensitization, right? So the initial phase, what happens? Whenever the allergen is exposed, the antigen presenting cell goes and presents to the T cell. T cell will produce by Th2 pathway, produces my immunoglobulin E, which goes and sits on the mast cell. This is the sensitization phase. The moment it sits on the mast cell, what will happen? Nothing will happen. Sensitized. The moment I get the antigen again for the second time, it will bind to the pre-existing antibody that will degranulate the mast cells. The moment it degranulates, you know what will happen. Then also I have two things. An immediate phase reaction, which happens within minutes due to the preform things like histamine and all those mediators are stored in the mast cell. Then a late phase reactant, which will take a few hours, 2 days. That will be due to newly coming WBCs, because interleukins also will be produced that will attract more and more new WBCs, right? That's the primary agenda of your asthma. This is the pathogens of asthma. Asthma classical symptom, wheezing, noisy sound, early morning. Most of them will be affected. That's asthma, right? Can anyone tell me, do you know any types of asthma? Any types of asthma? There are actually types of asthma. If you're not aware of it, I'll give you a clue. One of the asthma, we call it atopic asthma. Atopic asthmas are generally running in the family. There'll be history of allergy in your parents. You also will have. You will have positive skin test. Non-atopic asthma. You might not have history of allergy in the family, but a viral infection can trigger asthma. There, negative skin test will be there. Drug can induce asthma, like aspirin. Because when you give aspirins, it will block COX enzymes. So what will happen? More and more and more of leukotrienes will produce. That will push your bronchoconstriction more. Atopy asthma, right? Occupation-induced asthma, right? When you work in industries where there are particles, that can also trigger, right? Perfect, amazing. You know almost everything. Only one thing is left, airway remodeling. We'll talk about them also, fine? Perfect. Asthma, we discussed almost everything. You guys put in the chat box. You structure them into an answer. Everything is there in the answer sheet, whatever is required, right? It's a chronic airway inflammation of variable expiratory outflow characterized by wheeze, shortness of breath, chest tightness, which differs in intensity based on different times. Okay, perfect. So types of asthma, like I said, atopy, history of allergy in the family, classical IgE, all the classical pathogens we read is about atopy-induced asthma only, and they'll be positive for skin test. Whenever skin test is positive, it's IgE positive by default. Fine. Okay. Great. Non-atopic, no family history is due to any viral infections. Virus can trigger something. This can trigger asthmatic episode also, right? Negative skin test, no IgE here. Drug-induced, blocks COX pathway. LOX pathway will become more, which means more leukotrienes, more bronchoconstriction. It will tilt them towards that. Occupational, any occupation which comes to your mind with respect to particles, it will cause that. Fine. Coming to that Siddhi microscopy. Fine. Pathogenesis, yes, I do have predisposing factors. If it runs in the family, I do have few amount of pleomorphisms. If you can remember this, remember it. I'll tell you a clue. If you don't remember the exact interleukin name, try to remember this. This is a new thing which is required. Thymic stromal lymphopoietin. There is research is going on that, so do remember them. If you don't remember this interleukin, but you want to write genetic association, I'll tell you two things. Write them there. If you don't remember, if you remember, use the right one. If you don't remember, write family history present. That tells there's some genetic association. Second, twin studies show increased rate. This is how you expand the paper. When I say twin studies, when you study between monozygotic twins, both of them having the disease is more. That means this is genetic predisposition. Most of the books also will write them. This is a way to escape them, that's all, right? But if you can remember this. Interleukin 13 and interleukin 4, you can remember interleukin 13 at least because it's involved in the pathogenesis, both 4 and interleukin 13, right? And thymic stromal lymphopoietin and environmental predisposition. Hygiene hypothesis is very interesting. More hygienic you are, your immune system doesn't learn and they react hypersensitively to dust. That's what hygiene hypothesis is, which creates your pathogenesis. Same thing, pollen, antigen presenting cells, presence to B cells, Th2 pathway. Th1 is for granuloma. If you have difficulty in remembering, for me, primary headache, first most important headache is TB. 1 is granuloma. 2 is allergy. Fine. Because interleukin 4, which increases IgE, interleukin 5 produces eosinophil, interleukin 13 causes eotoxin and epithelial damage to the mucosa, respiratory mucosa. It will release histamine, right? So once this is there, and it will also, the increased IgE will bind to the mast cell, it will sensitize it. Okay, it should be like this. The moment mast cells are triggered by re-exposure, okay, it will cause granulation, immediate degranulation that will attract lymphocytes, eosinophils, and cause all these immediate phase reaction. And also it will release multiple other interleukins which will attract more and more new WBCs. Fine. The new WBCs will cause late phase reactions which takes much more time. Okay. Fine. Got it. So leukotrienes, smooth muscle mitogens, right? Slow reacting substance of anaphylaxis. These are the most important thing here. LT, C4, D4 and E4. C4, D4, E4 are the most important thing in asthma. B4 is a chemoattractant, not much involved in asthma, right? The problem with asthma is the chronicity. When the person keeps on having asthma attack again and again over a period of years, the airway remodels. That's something which is very, very important here. What happens is the entire airway becomes thickened. When the airway becomes thick, drugs will not work. Initially, it was like this. Bronchoconstriction, I gave salbutamol, it dilated. Now it's not just constricted, it's thick. Where to dilate? There's no space to dilate, no? That is very important. I have to prevent airway remodeling. Why there's airway remodeling? Because of leukotrienes. That's why Montelukast is very important for treatment. You'll have sub-basement membrane fibrosis, vascularity will be more, cells will be more, but the most important thing is this. The smooth muscle will become more because of the smooth muscle mitogens. The moment smooth muscle becomes more, the airway becomes thicker, will not let me breathe properly even without an asthma attack, and drugs start failing. That's very important with respect to asthma. Fine? Done? And like Siddhi said, though not useful findings, these are light microscopy findings. Right? You'll have Crayola bodies, Kirschmann spirals, Charcot-Leyden crystals, 3 C's. Charcot-Leyden crystal is eosinophil related. Galactin 10 is a component. You will see them in microscopy. Okay, Kirschmann, normal bronchus, constricted bronchus. The sputum also becomes like a spiral outside. That's Kirschmann spiral. That's all. The spiral sputum coming out from a constricted bronchus. As simple as that. Fine. Next, Crayola bodies. Crayola bodies are when I cough violently, the epithelium can come outside along with the sputum. That is shed bronchial epithelium, which are called as Crayola bodies. Right. There are 3 findings which can be seen in the sputum microscopy of asthma. Fine. Treatment, I will leave it to you. You have an entire chapter on asthma treatment, right? Write whatever you want. I'll leave it to you, but this is a simple thing about asthma. Fine. Ready for the last question? That's your lung cancer. Yes, no, maybe. I'll ask you a few questions. Let's go from there. Okay. What's the most common type of lung cancer? The most common type of lung cancer, whatever comes to your mind. Adenosquamous neuroendocrine or metastasis. Next question. Adenocarcinoma happens in the center of the lung or in the periphery of the lung? I would prefer metastatic as the right answer. Mets is by default most common than any primary lung cancer. But if it's a primary lung cancer, like I said, it's adenocarcinoma is more common than squamous cell carcinoma because of the change in smoking habit. Fine. And adenocarcinoma is more common in the periphery of the lung. If you have to name one lung cancer which has so many paraneoplastic syndromes, which lung cancer is that? One lung cancer with so many paraneoplastic syndrome. Which lung cancer is that? Anything which comes to your mind. By default, it is small cell carcinoma of the lung, right? Small cell carcinoma has so many paraneoplastic syndrome. I want you to remember the list, at least few common ones, right? The small cell carcinoma of the lung can have Cushing's, can have SAADH, can have Lambert-Eaton myasthenic syndrome, LEMS, Lambert-Eaton myasthenic syndrome. This is like myasthenia gravis, but the target is calcium channels, that's all. Squamous cell carcinoma will have hypercalcemia, but that's not the most common. Small cell carcinoma will have lots of paraneoplastic syndrome. The reason why I'm telling you this is, I saw in Jammu Kashmir paper, a difficult paper, they gave a history of 65-year-old person, smoker, had electrolyte imbalances. That was the premise of the question. Just they showed some nodule. What's the diagnosis? You should be able to identify, okay, it's a SAADH, syndrome of inappropriate ADH secretion, which has that. Sputum microscopy for asthma, forget it. It's theoretical. No one looks at the sputum at all. Okay? But we look at the sputum, I might see them. Not often, but I will see them for sure, right? So I can have a history of Cushing syndrome and point to a lung nodule in the lung. Could be a lung cancer diagnosis, not Cushing diagnosis. Lambert-Eaton myasthenic syndrome, you'll have antibodies against the calcium channel, which will act like not letting the acetylcholine going to the neuromuscular junction, like myasthenia gravis. It will be like that, right? Muscle weakness. Relating to a lung nodule, think of small cell carcinoma of the lung. Fine? Perfect? Okay, let's go to the content. First, we'll talk about squamous cell carcinoma. Okay. Squamous cell carcinoma, by default, it's a crude variant of smoke which causes squamous cell carcinoma. When I say crude variant, unfiltered cigarettes like BD, pipe, all of them cause squamous cell carcinoma, right? I hope pipe is unfiltered cigarette. Not sure about that, right? Because the smoke particles settle in the bronchus. They irritate the bronchus. First causes squamous metaplasia. The person will never stop smoking, continues to smoke, causes squamous cell carcinoma. Because it will cause more mutation of P53, retinoblastoma, this is in squamous cell carcinoma. Here mutations are not important in squamous cell carcinoma, but you have to remember these two. Few classical findings, central lesions. The only cancer which can have cavity on X-ray because of central necrosis and calcemia, all are C. Calcium elevated, necrosis in the central lesion, and your cavity in the X-ray, right? Why hypercalcemia? Because the tumor cell secretes PTH related peptides. Fine, that's it. Microscopy, I'll have classical keratin pulse. This I am sure you will remember. This is my favorite 4 feats of dysplasia. You can use this for every cancer from head to foot. Pleomorphism, which is if you have time and if you don't know what to write what is pleomorphism? Variation in size and shape. High NC ratio. Again, if you want to fill pages, right, there will be increase in the nuclear size. If you want to write more, right, then only cell can divide. Loss of polarity is orderly arrangement will be destroyed. Squamous cell is like this, right? The orderly arrangement will be gone. That's loss of polarity. Mitosis by default, I'll have either increase in mitosis or I'll have atypical mitosis. Okay, that's what will happen for visual dysplasia, right? IHC, best is P40, but P63 also is a very good marker for diagnosis. Both of them are nuclear markers and both of them are good for diagnosis, fine? That's in short about squamous cell carcinoma. Adenocarcinoma is the most common. And if I want you to remember one genetics with lung cancer, never forget adenocarcinoma genetics. Others are fine with me. Even if you forget, not required. Because as on date, if anyone diagnoses adenocarcinoma in real life, without doing genetics, we cannot move to the treatment protocol. If they're affordable, I'll do. If they're not affordable, I can't help. I will not have a proper decision making there, right? So adenocarcinoma, there are few things you have to remember. Most common in men, most common in women, most common in the world, most common in India, most common in smokers and also non-smokers. Important, right? Because non-smoker, the peripheral alveolar cells have repeated damage and division. More and more cell division there's more chance of mutation. Fine variety of smoke reaches the alveoli, irritates the alveoli and forms a tumor which resembles alveoli. Gland-like tumor, we call it adenocarcinoma. All three mutations I want you to remember. KRAS, this has worse prognosis if it's present. EGFR, right? That's the most common mutation seen in Asians and Indians, and ALK1. Right? And EGFR as a targeted therapy, that also is better for us. Fine. Okay. So there are adenocarcinoma is peripheral, adenocarcinoma is single, and they'll be irregular, and adenocarcinoma can spread via the alveoli to the other lung. So if we have bilateral lung cancer, I'll think of an adenocarcinoma. Real student, I told you, na? See, if let's say a person is a non-smoker, I have the center of the lung and I have the periphery of the lung. Periphery of the lung, the alveoli is very thin. So the chance of damage is more. Chance of regeneration is more. Whenever there's damage, regeneration, there's a chance of mutation is also more because cell division causes errors. That's why the cancer here is more. Cancer in the alveoli is more. So it looks like a alveoli. That's adenocarcinoma. Got it? Okay. No, not at all. Definitely smokers will have increase in risk than non-smokers, but non-smokers also can have one cancer. Predominantly it's adenocarcinoma. Fine. Got it? Fine. So yeah, three types in adenocarcinoma. Atypical adenomatous hyperplasia, adenocarcinoma in situ, and your invasive adenocarcinoma. Less than 5 mm, tiny lesion, right? You cannot pick them. Rarely you pick it up. You take an CT scan for something else. You pick this up, and you'll have few dysplastic cells in biopsy. Lung completely normal. Few of them are high NC ratio and abnormal. That's all. In situ, 3 to 5 centimeter. In situ, the only thing required for me is it has not invaded the basement membrane. How do I identify them in microscopy? You won't have desmoplasia between the alveoli. The moment infiltration happens, desmoplasia happens. And that's a classical pattern called as lepidic pattern. This is lepidic pattern. If you can see, it looks like big flies or butterflies sitting on the line. For the person who first saw it, looks like that. But there are basement membrane and top of that I have ugly dysplastic cells. That's called as a lepidic pattern. Invasion, any size, the only thing is basement membrane invaded. How will I know? It will go into the interstitium and have desmoplastic reaction, right? And obviously you'll have malignant glands. Malignant glands, invasion present, invasive. Malignant glands, no invasion, lepidic pattern in situ, and atypical adenomatous hyperplasia. Fine. Okay. Marker is TTF1, napsine. Both are good enough for me. I don't know which is superior, which is inferior. Both are decent markers. Both has to be done for me to tell it's primary lung adenocarcinoma. Fine. Perfect. Then let's come to neuroendocrine tumor. Neuroendocrine tumor, I have typical carcinoid, I have atypical carcinoid, I have small cell carcinoma. My focus is more on small cell carcinoma because of the paraneoplastic syndrome, which can give a easy long answer question. Typical carcinoid, both can be the central lesion, right? So typical carcinoid mostly grows endobronchial, and also it's called as collar button lesion. Remember, it could be a Viva question. Why collar button? Because let's say this lung, the bronchus, I'll have a tumor here which can break and go outside. Looks like the collar button, right? If you want suit, you will have a collar button. The button like this, right? So it protrudes outside. So it looks like a collar button. We call it a collar button lesion, right? Typical carcinoid, you'll have a classical nesting pattern, no or minimal pleomorphism, no necrosis. This is very important. Mitotic out of less than 2 per 10 high power field. Okay. And for all neuroendocrine tumor, this is a common feature. High power will have salt and pepper chromatin. Dark blue, light blue in the chromatin, right? Atypical carcinoid will have may or may not have necrosis, plus or minus. Will mostly have sheets of tumor. There is no nesting pattern or organoid pattern. And the most important thing is mitotic count. Become 2 to 10. I want you to remember this. 2 to 10 is atypical, less than 2 typical, more than 10 small cell carcinoma. That's a very easy way to remember. Rather than remembering all three, just remember the center one alone, right? Next is small cell carcinoma. Most aggressive, almost always involved in smokers. Small cell carcinoma in a non-smoker, this person is bluffing that he doesn't smoke. It's like that. 99.9% it will be seen only in smokers. Okay. Old name was oat cell carcinoma. And like I said, most of the time presents paraneoplastic syndrome. Remember Cushing's, SAIDH, and your Lambert-Eaton myasthenic syndrome. Fine. Sheets of tumor cells, necrosis by default will be present. In the perivascular area alone, it will retain, and that gives an Aso-Party effect. Surrounding the vessels, you'll have bluish smudging of DNA material. Okay, that's called an Aso-Party effect and very high mitotic count. Remember this word. This word is important for me to call it small cell carcinoma and the paraneoplastic syndrome. And high power is also have salt and pepper chromatin by default. 99.9% small cell carcinoma will always be seen in smokers. It's like very, very unlikely a non-smoker will develop small cell carcinoma. Why not 100%? See, Zishan, medicine is very, very tricky. You can never use a statement, it will never happen, it will always happen. Because there will be one case which will say, there's an exception. That's why in an entrance exam, if an option says always present, that option is wrong. If an option says it will never happen, that option is wrong. Because medicine is always about the ambiguity. That makes medicine beautiful. Okay, let's come back to this. This is a marker for every neuroendocrine tumor. Be it small cell, be it carcinoid, be it atypical carcinoid, be it any neuroendocrine tumor anywhere in the body. Fine. Hi, Ahmad. Okay, this is common marker, synaptophysin, chromogranin. NSE is neuron specific enolase neuroendocrine, because there's one more NSE in hematology called as non-specific esterase. That is different, this is different. Fine. Okay. Yeah, there are with respect to different diseases, there are different logics, Shan, that's all. Okay. That's what is about small cell carcinoma and the other lung cancers. Fine. Okay, so we have completed most of the things with respect to your CVS as well as lung. So tomorrow we'll look at, I think, GIT and liver. We'll do the same thing. Next Sunday is holiday. Next 2 more days, we'll complete the other 4 systems of the systemic pathology, right? So next 4 days, be with me. We'll completely revise most of them. Fine. Okay, bronchogenic carcinomas, paraneoplastic syndrome. Write about these 3, Dharmishta, and also write about hypercalcemia and small squamous cell carcinoma of the lung. Okay. And if you want to write for a 5-mark question, write that hypercalcemia can be seen in small squamous cell carcinoma of the lung because they secrete parathormone related peptide. That's the reason it increases the calcium levels. Small cell carcinoma nucleus, the cells secrete your ACTH like substance which increases the glucocorticoid levels, which cause Cushing syndrome. Same ADH will be secreted, and like I said, Lambert-Eaton, it will increase the immunological phenomenon, antibodies against the calcium channels, which releases acetylcholine. Because the calcium channel is destroyed, acetylcholine cannot function. Because of that, you'll have muscle weakness. Suhas, Aso-Party effect is very simple. See, if you have, let's say, there's a blood vessel. Okay, all these places I have tumor cells. All these tumor cells are dying because a very high grade tumor. So what will happen? Karyoretic debris will be there, no? That debris will get deposited here. Because of the cell death far away from the blood vessel, all the karyoretic debris deposits here. smudged DNA surrounding the blood vessel is also a body effect. Fine. Dharmishta, if there's a question like that, write 4 and write a little bit about Cushing syndrome symptoms also, Lambert-Eaton symptoms also, SAIDH symptoms also, so that it will look like good answer for a 5-mark question. Got it? Any other doubts? Let me know. If not, we'll call it a day. See you tomorrow. I'll share the questions in the group. Guys, if you are in the group and if your friends is not there in the group, please share the PDF to them, right? It's difficult for me to reach to everyone. So please do share the PDF to them, fine? Thank you guys. Thank you. Bye-bye. All the best. See you tomorrow.